Good evening to all doctors. I'm thrilled to welcome you all for today's very informative webinar on the ventilator blueprint, Taming the ICU Monster. I'm Vijay, manager at Mediversal Academy, and I have the privilege of introducing to our esteemed speaker, Dr. Navonil Dutt. Dr. Navonil Dutt has done MBBS, FIC, DNB in pulmonology, working since 2020, serving in frontline critical care during COVID pandemic. He also teaching and moderating and conducting seminars since 2022. Is also part of West Bengal Rheumatology Association and very regular to their CMEs and seminars organized across the country. During MBBS, he was a part of SAMSA, which is South Asian Medical Student Association from 2017 to 2021. In 2019, he was awarded with the best poster case presentation at the International Undergraduate Conference, Conscience 2019 in JIPMER Pondicherry. Over to you, Doctor.
Thank you. Okay, first of all, am I audible and visible? That is the first question because I am not able to see myself for some reason.
You're audible and you're visible, Doctor.
Okay, good. Okay, so good evening to all who have joined in, and I hope you're all doing well. So once I have a heads up, I think we'll be using this. Yeah, so we'll be starting off now with the webinar, and thank you to all the ones who have joined. There's quite a good number of people who have joined, and I hope you'll be joining in soon, the rest as well. Now, practically, this topic is something that I've been waiting to take for a very long time, but then, like, better late than never. But one thing I want to begin in a very, very honest and a very transparent note before I say anything, that covering a ventilator in 2 hours is impossible. Not even next to impossible, it's impossible. Because ventilator is a thing which, as I call, it's an idiot who does not understand, but you have to take years to understand that idiot. It is about being a wedded husband or a wife to an idiot, a person who does not understand anything, but aapko use samajhna hai, and you will have to understand what to do in order to control the ventilator, because ventilator ko khud se kuch karna nahi aata hai. ठीक है? So naturally, when we talk of such an object which is just going to blindly follow my commands, I need to be well acquainted with the basic terminologies of a ventilator, the very basics about how a ventilator is supposed to work, and what are the conditions in which basically a ventilator is going to be used in. And as I said, practically doing that in 2 hours is impossible. It almost is a 20-hour course basically on ventilators. Even in workshops, we say it's at least an 8 to 9 hour course. That's the bare minimum. So now, how will I be doing it in 2 hours? I will not be covering the in-depth, in toto details about the ventilator, because trust me, zarurat nahi hai. If you open an anesthesia or a critical care textbook, just like what I did when I was studying about the ventilator, मुझे कुछ समझ में नहीं आया था, because if you cannot understand or study a ventilator from a book, what rather happens is you start working with the ventilator. It is like starting your marriage with an idiot, and gradually you start understanding कि ठीक है इस idiot को मुझे कैसे काम करवाना है, इस idiot से कैसे मुझे काम निकलवाना है, to be honest. And the ventilator is something that you gradually start getting synchronized to, and you start being in sync with what you want to do and what are the commands and instructions that you want to set. Now, why do I call a ventilator an idiot? Because basically the only thing it does is to give breaths. That is the only thing. But kitna breath dena hai, when to give the breath, how much to give the breath, what is the rate of the breath, ye sara cheez as a doctor, as a clinician, I am supposed to decide. Okay. Now, I've got a couple of balloons with me. I'm first wanting a heads up from you to know whether you all can see this yellow balloon, the smaller yellow balloon, and this green balloon. Can I have the chat box open for everyone to answer? Are you all able to see the balloons? Great. Okay. So I will be beginning the slides in a couple of minutes. And as always, Dr. Rimjim is going to be sharing the screen for me so that it is possible for you to see me, because there'll be a lot of demonstration with these balloons that I'll be showing. And also at the same point of time, you can quickly go in through the slides. So if You are disappointed कि सर आपने वो ग्राफ नहीं करवाया, ये ग्राफ नहीं करवाया, you know, आपने ये सपोर्ट सिस्टम नहीं दिखाया, ये वेंटिलेटर मैकेनिक्स नहीं समझाया, then I am already telling you, you will be disappointed a bit. But for the larger audience who have no clue on what a ventilator is, and I suppose that is the niche of audience that I am going to deal with, जिनको वेंटिलेटर नाम से बहुत डर लगने लगता है, because that is usually what happens when we hear about ventilators and ECGs. We start getting afraid of what a ventilator is. We start getting afraid of what an ECG is. So my work is to remove the fear. डर भगाना मेरा सबसे पहला काम है, so that from this webinar you can build upon this, or maybe just like Dhurandhar came up with its part 2, we can always have a part 2 of this webinar, where we can talk in details about certain conditions, and about what are the indications, and the strategies in which to ventilate in those conditions. So yeah, I will be beginning this. So welcoming you all aboard on this journey. We'll have a lot of memes, we'll have a lot of fun, we'll have a lot of relaxations as well. But उसके साथ पढ़ाई भी करेंगे और मस्ती से करेंगे, खूब अच्छे से करेंगे, है ना? ठीक है, चलो. So good evening, Dr. Rimjim. I will tell you to begin the slideshow. Yeah. So when I begin this, let us first imagine दोपहर के 3 बज रहे हैं. Okay, I just want Dr. Vijay, Vijay sir, can you just turn your mic on once?
Sure, doctor.
Vijay sir, I am not able to see myself, and that is causing me a lot of trouble because मैं खुद को देख नहीं पा रहा हूँ.
Actually, you are visible. You are very much visible.
No, the reason I'm saying that is because I am not able to understand कि मैं जब कोई balloon या किसी चीज से demonstration दिखाऊंगा, how much will I be able to be seen?
Okay.
Do you
Since
want
you have
me to?
shared your screen, I don't think you will be able to see what you
No.
are
I am
sharing.
not sharing my screen. My screen is being shared by Rimjim.
Okay.
Dr. Navonil, you can add yourself into a different
Spotlight, yeah.
different tab or different iPad or something.
Okay.
So that way you can see yourself.
Yeah, perfect.
Or else yeah. I'll send you link, doctor. If you can open that link from another device.
Yes, please send me the link on my WhatsApp. Okay, thank you. Yeah, that should be good. Yes. Okay, so I'll be beginning with the slides. And as I said, we'll talk about a tale of 4 cases. Just imagine it is a rainy afternoon and it is 3 p.m. You're sitting in your critical care, department or the ICU with your team of doctors and technicians and nurses. गरम गरम चाय पे आप चुस्की लगा रहे हो, and you are kind of happy कि चलो today the ICU is shant, everything is looking good, no big worries coming up. You're talking about your Goa trips with your friends, है ना? या फिर maybe you're playing Ludo on your mobile, and that is exactly when, as we all say, कि जब ICU सबसे शांत रहता है, something imminent is coming. So we have 4 cases who drop in within a span of half an hour. Very common scenario for all of us who have worked in the ICU, and for the ones who will be going to the ICU. Yeah, as I say, agar ICU shant hai, something is about to happen. So let's take you to the tale of 4 cases. Our first case is going to be, yes, please change the slide. Our first case is going to be a 45-year female. As you can see, she was found with an empty bottle of alcohol, an empty bottle of sleeping pills, and she's having a heart rate of around 125 per minute, a respiratory rate of 20 per minute, a BP of 98/40, which is hypotension, a GCS of 8, which means that she has come with very poor consciousness, but an SpO2 of 100%. So, considering the fact that her GCS is so low, do you all agree with me that she needs to be ventilated? She needs to be intubated. Everyone is in sync with me. I should find the chat box lightening up today. Everyone is in sync? Yes, exactly. So because we need to protect her airway, she is unconscious. So the first dictum that we say, जो इंसान बात नहीं कर पा रहा है, that person has an imminent danger of an impending airway compromise. One who cannot talk, one who is unconscious, is definitely someone whose airway is going to be compromised. And that unconscious should be a reversible cause of consciousness. फॉर एग्जाम्पल, अगर किसी को वेसोवेगल अटैक हुआ है, किसी को मानो आपने बताया कि यार आपको आज 25 करोड़ लॉटरी में आ गए एंड सडनली वो गिर गया, ही इज हैविंग अ वेसोवेगल अटैक, ठीक है, फॉर दैट यू विल नॉट बी रिक्वायरिंग टू इंट्यूबेट द पेशेंट. But anytime, whenever there's an irreversible cause or a prolonged cause of unconsciousness, that is exactly when, in order to protect the airway, you will have to think of starting to intubate the patient. Okay? That is our first case. Let us see what the second case has come. What is the second case for us, Dr. Nimjum? The second case is, again, ये patient हमारे hospital में था. This patient was actually in the general ward. It was a patient of pneumonia. He's an old person. He was being maintained well with oxygen and antibiotics, and he was kind of doing well. But suddenly, since 12 p.m., this patient has started to desaturate. This patient has now been shifted to ICU. A call has come to us, and we are being told that you need to be quick for this patient because this patient is desaturating rapidly. There is very high-end hypoxemia developing, and this patient again needs ventilation. What is the third case for us? Case 3 is my favorite. This is my favorite Amma, 68-year-old female. She's a smoker. She's a known case of COPD. Has come unconscious. When she was admitted, she was unconscious. Currently, she's having a gasping method of respiration. So currently she's gasping. Heart rate is 125 per minute. BP is around 100/65. Saturation looks really poor on room air at 65%. The weight is around kind of 65 kgs, and definitely there shouldn't be a doubt to it that you will need to ventilate this patient. Correct. Now, case 4 and the final case. This patient is another elderly woman who was admitted to us with recurrent episodes of UTI, chronic UTI, which has now developed into urosepsis. This patient has worsened now and is now running a risk of MODS, because we all know whenever there is sepsis or septic shock, there's always a chance of MODS or multi-organ dysfunction happening. So this patient now needs to be ventilated. We have these 4 case scenarios with us. Now, Jesse, as an ICU RMO or a resident, you are playing Ludo, having your favorite chuski of your garam chai at 3 p.m. in the afternoon on a day when you feel कि चलो भाई और 2-3 घंटे की ड्यूटी बची हुई है, let me easily pass on these 3 hours, and suddenly you are loaded with these 4 calls. पहला चीज जो दिमाग में धक्का लगता है, दिल पे सदमा पहुंचता है कि भाई oh my god, ventilation फिर से. Please raise your hands. How many of you have experienced this? How many of you are accustomed and well acquainted to what I'm saying? Everyone who have worked in the ICU? Yes. And I feel you all can relate to this fact that no matter how good you are, how acquainted you are, and no matter how confident you are, डर तो भाई लगता है, definitely. And that is why my next slide is to all make you work, to make you smile and laugh. So Twinkle, you're currently working. Okay, good luck for your postings tomorrow. Next slide. So in this moment, this is all that I'll have to say to you. So yeah, कुछ वजह से the sound is not there, but as I always say, कि घबरा मत. The sound is back.
क्या तू मेरा चला तुझे फैंटा पिलाऊं.
चलो फैंटा पिलाता हूँ, and let us try to make this interesting. डरना नहीं है. 1 bottle of Fanta, all of us are going to share, and we are going to talk in through all these 4 patients. ठीक है? One more time the audio for every one of us.
क्या तू मेरा चला तुझे फैंटा पिलाऊं.
चलो, great. Okay, so let's move in. Let's move into the next slide. Okay, so as we say, L'Oreal Paris keeps on saying 5 problems, 1 solution. वैसे, whenever a patient is coming to us in the ICU, whenever there's a critical patient who is in need for an intubation or a mechanical ventilation, या फिर is in need of this device called a ventilator. हमें दो चीज समझना है कि there are mainly two problems in life. One problem is the problem of oxygenation. The other problem is the problem of ventilation. Now, what is the difference between oxygenation and ventilation? When I talk of oxygenation, कुछ देर के लिए let us forget this slide. Okay, can we shift the slide to Jamil without playing? Don't play the audio. Shift it to the next previous slide. Shift it to the previous slide. So as you all can see me, how do we breathe in? Let us start from our class 3-4 levels, जहाँ पे हम लोग स्कूल में पढ़ते थे और हमें सिखाया जाता था कि हम सांस कैसे लेते हैं. So we know this. Whenever normally we are supposed to breathe, we will be having a chest expansion. That chest expansion is going to create a negative pressure. That negative pressure is what is going to suck the outside atmospheric air into our lungs. Right? So we know this, that pressure is inversely proportional to volume. So as the intrathoracic pressure is going to increase, it is going to suck the amount of air from the atmosphere so that we are able to breathe. That is mainly the process of inspiration. Whereas on the other hand, expiration is something which is a passive process. Yani ki we will, the lungs will, I mean, the alveoli will recoil and they'll compress so that the inside air is being thrown out, into the atmosphere. But the problem is, since our class 3-4 levels, we were always taught that we take in oxygen and we throw out carbon dioxide. However, that is not true, because if really we were only taking in oxygen and throwing out carbon dioxide, do you all agree? And for that, again, I will want you all to be active in the chat box, that whenever we give mouth to mouth breathing to a patient who has collapsed, say in the mall, there's a collapsed patient. Abhi tak there is no paramedic that has come. You are the only doctor or healthcare professional at the scene. So you have started your CPR and you're giving rescue breaths to the patient through mouth to mouth. So जब हम mouth to mouth breath दे रहे हैं, you agree, right? We are throwing out carbon dioxide according to the concept that we studied in our elementary schools, that we take in oxygen and we throw out carbon dioxide. So technically, I can say that we are going to throw out carbon dioxide to the patient. However, that is not true. Why? Because even the expired the expired breath that we are giving to that patient, it is not carbon dioxide rich, it is actually air. So we take in air, we throw out air. Air has a mixture of these gases, which is oxygen and carbon dioxide, and also nitrogen, which we are not going to talk of because that is out of our discussion league today. So we take in air, we throw out air. The only difference in the inspired air and the expired air is the difference of the oxygen and the carbon dioxide content. Is this clear with everyone? आगे से हम लोग नहीं बोलेंगे that we take in oxygen and throw out carbon dioxide. That is for class 3-4 के बच्चे. Can we all agree to this, that we take in air and we throw out air? Because when we are giving rescue breaths to a patient, suppose मैं mouth to mouth किसी को दे रहा हूँ rescue breath, what I am basically doing is, अगर मेरी normal inspired air में there is 21% of oxygen, everyone agrees. Geography में हम लोग पढ़े 78% of nitrogen atmosphere में 21% of oxygen है. The remaining is carbon dioxide, right? So when I am inspiring a normal air, I am taking in 21% of oxygen. But when I'm giving a rescue breath, can anyone tell me what is the amount of FiO2 that I'm giving to that patient? Anyone in this chat box? Anyone who can reply? What is the amount of FiO2 that I'm giving to a patient in a rescue breath? जब मैं मुंह से सांस फूक रहा हूं उसके अंदर, मैं कितना FiO2 में उसको ऑक्सीजन दे रहा हूं? Anyone? किसी को पता है? ओके, नहीं पता. ना 30%. ओ माय गॉड, नहीं 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 नहीं, ओ माय गॉड, 30% तो नहीं भाई. 30% हम लोग फेस मास्क ऑक्सीजन पे लगाते हैं. मैं खुद 21% में सांस ले रहा हूँ, 30% कैसे छोड़ूंगा? है ना, वो नहीं हो सकता है. सो I will be giving around 15 to 16% of FiO2. Always remember, when I'm giving a rescue breath to a patient, मैं 16% of oxygen उसको दे रहा हूँ. ठीक है? I am giving that amount of oxygen so that his respiration, no, not 21 darling, 21 नहीं है. Dr. Aparishit or whatever your name is, I'm sorry, it went away. So जब हम सांस ले रहे हैं, the inspired air is containing 21% of oxygen. But जब मैं सांस दे रहा हूँ किसी को, when I'm giving rescue breath to a patient, it is going to be 16% या फिर 15% of oxygen that I give. ठीक है? So which means that my expired air also contains a decent amount of oxygen. Hence, this entire theory that we learned in our एलिमेंट्री स्कूल डेज कि हम लोग ऑक्सीजन अंदर लेते हैं और कार्बन डाइऑक्साइड छोड़ते हैं, इज रॉन्ग. तो हम लोग हवा अंदर लेते हैं और हवा बाहर छोड़ते हैं. इज दैट ओके विथ एवरीवन? वी टेक इन एयर, वी लीव आउट एयर. इज दिस कॉन्सेप्ट फर्स्ट क्लियर? क्लियर? फैंटास्टिक. ओके, गुड. सारे लोग आप मुझे थम्स अप की इमोजीज भी भेज सकते हो. दैट विल मेकिंग मी अंडरस्टैंड दैट यू आर गेटिंग व्हाटएवर आई एम सेइंग. ओके, नाउ व्हाट डू आई मीन बाय ऑक्सीजनेशन? ये जो मैं बाहर से अंदर की तरफ एयर ले रहा हूं, द इंस्पिरेशन प्रोसेस which is sucking in air from the outside environment, this is richer in oxygen. It is richer in oxygen. Okay, agreed everyone? Now, if there is a problem in me breathing in an air which is having either lesser oxygen, that means either I am having a problem in the FiO2. Normally, I am taking in 21% of oxygen. But suddenly, when I go to the Himalayas, same, I am ascending at a height of 5,000 feet. What is exactly changing? Can anyone in the chat box reply to me? अभी मैं कोलकाता में बैठा हूँ या वेस्ट बंगाल में बैठा हूँ, मैं नॉर्मल सांस ले रहा हूँ, and I am breathing in a 21% या फिर 0.21 FiO2 of oxygen. Whenever I am going to the Himalayas, है ना, say Shimla, Kulu Manali, Leh, Ladakh, what is happening? Is the FiO2 going to change? First answer my question, is the FiO2 going to change? In higher altitudes, does the FiO2 change? No, no, Dr. Apekshit. No, Dr. Apekshit. In the higher altitudes, my dear, the FiO2 never changes. It is only the P atmosphere or the atmospheric pressure that changes. So when I am at sea level, I am breathing at an atmospheric pressure of 1 atm, that is 760 millimeters of mercury. जैसे मैं ऊपर ऊपर उठता रहता हूं, when I ascend to 5,000, 10,000 feet, what is going to happen is the atmospheric layers of air are going to get thinner. Whenever the atmospheric layers start getting thinner, it clearly means that there is a drop in atmospheric pressure, which means at sea level, 1 atm or 760 millimeter of mercury was able to provide me 21% oxygen. That was in turn maintaining a PaO2. Normal PaO2 is around 90 to 100 millimeters mercury. Everyone in this segment agrees with me. Normal PaO2 is 90 to 100 millimeters mercury. Okay. So at sea level, at Kolkata, I was breathing at an atmospheric pressure of 1 atm or 760 millimeters of mercury. And at this level, 760 millimeters of mercury, I was able to breathe in 21% of oxygen, which was contributing to a PaO2 of around 90 to 100 millimeters of mercury. When I'm ascending to Leh Ladakh, my FiO2 is not changing. But because the atmospheric pressure is decreasing, now the same PO2, to maintain the same PO2, my body will find it very, very difficult. So what changes basically in higher altitude is the atmospheric pressure or the barometric pressure. It is not the FiO2. Even in Leh Ladakh, people who are living in Leh Ladakh, they're also breathing in 21% oxygen, but at a lower atmospheric pressure. Is that clear with everyone? Is that clear with everyone? So, do you now realize that what do I mean by oxygenation? The amount of oxygen that is entering into my body. This amount of oxygen that is entering into my body, that is what I know, I mean commonly known call as the oxygenation. And any defect in oxygenation predominantly means two things. या तो मैं लेह लद्दाख में बैठा हूं, where the atmospheric pressure is so low that that amount of atmospheric pressure is not able to maintain a certain amount of saturation in my blood. Is that clear? Nahi to, if I am really in Kolkata or say in ICUs, in the ICU settings, what we usually find that whenever a patient has a defect in oxygenation, it clearly cannot be a problem of FiO2 anymore, because in the ICUs, I am either giving an NRBM, or I am giving a face mask, or I am giving a HFNC, or I'm giving a nasal cannula, or I'm putting the patient on a ventilator. अगर मैं किसी patient को ventilator पे डाल रहा हूँ and I'm putting an FiO2 of 100%. You all agree कि whenever a sick patient comes to us, the initial FiO2 that we set on the ventilator is 100%. Everyone is agreeing to this. So if a patient in the ICU is developing a defect in oxygenation, it clearly means that the problem cannot be FiO2, क्योंकि मैं तो 100% ही डाल रहा हूँ उसको. वो नॉर्मल रूम एयर पे 21% पे ले रहा था, अभी मैं उसको वेंटी पे 100% FiO2 डाल रहा हूं. तो प्रॉब्लम अगर फिर भी रह रहा है, इट मींस दैट द प्रॉब्लम ऑफ ऑक्सीजनेशन इज नॉट एट्रीब्यूटेड टू FiO2. Then what is it attributed to? We will be looking at this later. So till now, what did I say? There are two common problems in life. First problem is a problem of oxygenation. The second is a problem of ventilation. Okay? Just like L'Oreal Paris says, 5 problems, 1 solution. L'Oreal Paris, हम बोलेंगे 2 problems, 1 solution. Ventilator. Now, ventilator ऑक्सीजनेशन के डिफेक्ट को भी संभाल सकता है, वेंटिलेशन के डिफेक्ट को भी संभाल सकता है. बट व्हाट डिड आई से इन द इनिशियल पार्ट? वेंटिलेटर इज एन इडियट. संभालना वेंटिलेटर को नहीं है, संभालना हमें है. सो वी नीड टू अंडरस्टैंड व्हाट इज द प्राइमरी डिफेक्ट, and whenever we know the primary defect, we can then move on to understanding what are the settings that we need to give in the ventilator. इसी पेशेंट की बात करते हैं. एनी पेशेंट हु इज कमिंग टू मी विद एन ऑक्सीजनेशन डिफेक्ट इन द आईसीयू, यानी कि दिस पेशेंट इज हैविंग प्रोफाउंड हाइपोक्सीमिया, यानी मानो उसका PaO2 इज अराउंड 40 या 50 मिलीमीटर ऑफ मर्करी, डेस्पाइट गिविंग FiO2 ऑफ 100%. उसका PaO2 ज्यादा इंप्रूव नहीं कर रहा है, 50 या 60% ही रह रहा है. एक बात तो पक्का है कि despite giving a full FiO2 of 100, if this patient is still having an oxygenation defect, the problem is definitely at the level of the alveolus. Maybe this patient lung, which is supposed to say contain millions of alveoli, मैं उसमें से millions में से 100 alveoli को एक section में बाहर करके निकालता हूँ. Let me now imagine कि there are 100 alveoli in the patient which are supposed to take part in gas exchange. But out of these 100 alveoli, say 60 alveoli are diseased. Q diseased? It can be diseased due to ARDS. It can be diseased due to pulmonary edema. It can be diseased due to pneumonia. So this case, when we were talking of the cases, we had this case too where it was a patient of pneumonia who was worsening and desaturating. So what was exactly happening at that point of time is, we can say that this patient is having an oxygenation defect. And how are we saying that? क्योंकि FiO2 तो मैं 100% दे रहा हूं, उसके बावजूद भी पेशेंट सैचुरेट नहीं कर पा रहा है. द पेशेंट इज स्टिल desaturating. Even on a ventilator, if the patient is desaturating, the problem is, instead of the 100 alveoli which should have taken part in the respiratory process, 70 of them are damaged. Either it is having pus in the form of pneumonia, or it is having water in the form of pulmonary edema, or it may have blood in the form of diffuse alveolar hemorrhage. In all of these cases, one thing is very common, that 70% alveoli खराब है. यानी कि now the oxygen that I am pushing in, चाहे वो normal air से हो या venti से हो, it is going only to the 30 alveoli. इतना correct है? Is everyone understanding what I am saying? सीधी और सिंपल भाषा में, for people who are not understanding this, मैं एक बात बोलूंगा. You will all have to answer to me. So Dr. Twinkle, Dr. Chanakya, and all the other ones who are here, Apekshit and everyone. मानो मेरे पास 2 alveoli है. I have 2 alveoli. चलो ले लेते हैं. This is one balloon, the green balloon. This is the other balloon, the yellow balloon. सबको दिख रहा है ये 2 balloon दिख रहा है? I've got these balloons specially for you today. दिख रहा है सबको balloon दिख रहा है? Great. अब मानो this is a diseased alveoli. This is a normal alveoli. Can you please tell me, when oxygen is being given, suppose मैं ventilate किया हूं आपको, वेंटी से आपको ऑक्सीजन डाल रहा हूं, 100% FiO2 में डाल रहा हूं. Which out of these 2 alveoli, I repeat, this one, the green one is the diseased alveoli, the yellow one is the normal alveoli. Oxygen will go to which alveoli? The diseased alveoli or the normal alveoli? Can you please tell me? जब मैं सिर्फ मेरे पास 2 alveoli है, एक खराब alveoli है, एक normal alveoli है, the oxygen will go to which alveoli? Yes, Dr. Apekshit, absolutely correct, my dear. No, Sagar, both नहीं जाएगा, दोनों में नहीं जाएगा. This is exactly where the concept of hypoxic pulmonary vasoconstriction comes in. This is a very important topic that I want you all to remember. Normally, हमारे body में, whenever there is a setting of hypoxia, every organ, every tissue wants to be perfused more. Therefore, they will vasodilate. Do you understand? जब हाइपोक्सिया होगा, आपकी ब्रेन को भी ऑक्सीजन की जरूरत है, आपके हार्ट को भी ऑक्सीजन की जरूरत है, आपकी किडनीज को भी ऑक्सीजन की जरूरत है, आपकी जीआई सिस्टम को भी ऑक्सीजन की जरूरत है, लिवर को भी जरूरत है. So all the blood vessels in these particular organs will dilate, except the lung. This is called commonly the concept of hypoxic pulmonary vasoconstriction. जहां पे क्या बोला जा रहा है? If I have 2 alveoli, and we know that whenever we are talking about alveoli, I'm not just talking of the alveoli, I'm also talking of the blood vessel that is perfusing the alveoli. इतना everyone is clear कि सिर्फ alveoli नहीं होता है, एक blood vessel भी होता है जो उसको perfuse करता रहता है, एक नदी की तरह बहता है वो. हाँ देखो, यहाँ से ऑक्सीजन अंदर आता है, और ये ऑक्सीजन डुबकी लगाता है। कहाँ डुबकी लगाता है? इनटू द रिवर ऑफ द ब्लड वेसल। इस रिवर में कौन जा रहा है? हीमोग्लोबिन जा रहा है। सो दिस ऑक्सीजन डिफ्यूजेस थ्रू द एल्वियोलो कैपिलरी मेम्ब्रेन इनटू द कैपिलरी. Here is the capillary, here is the alveolus. The oxygen simply dives into the river of the alveolary capillaries so that it can diffuse and mix with hemoglobin to form oxyhemoglobin. है ना? But whenever there is a diseased alveoli, what happens is hypoxia induced vasoconstriction happens in the pulmonary bed, which means whenever there is a diseased alveoli and a healthy alveoli, oxygen will be preferentially sequestered or shunted. Let me say, oxygen will be preferably sequestered or shunted to the normal healthy alveoli. This is also what we call as a shunt formation. So whenever in our body there are two alveoli, one is healthy, one is abnormal, oxygen will preferentially love going to the normal alveoli. So as I said, in a setting of a pneumonia patient who is having his alveoli filled with pus, or pulmonary edema patient or ARDS patient जहाँ पे अंदर fluid है, these alveoli are diseased alveoli and hypoxia will cause a pulmonary vasoconstriction. No matter how much FiO2 of 100% you will deliver through the ventilator, these alveoli will not be receiving the oxygen due to the pulmonary vasoconstriction. Is this clear? So what do I need to do? What do I need to do? I have two options. Most of the time, what happens is, imagine this alveoli. This is a diseased alveoli. How is a normal alveoli supposed to function? Like this. This is how a normal alveoli is supposed to open up whenever a certain amount of pressure is given. So this is what a normal alveoli is supposed to do. Imagine this alveoli is now diseased. So let me take up the diseased balloon. The alveoli is diseased. Whenever the alveoli is diseased, it will start to collapse. Why will the alveoli start to collapse? Normally, the alveoli are kept open due to the presence of something which is called a surfactant. What is a surfactant? Surfactant is a small molecule which is acting so that the surface tension in between the walls of the alveoli are reduced. So, let me repeat, there is something called surfactant that reduces the surface tension between the walls of the alveoli. In the absence of surfactant, when will surfactant be absent? Either when the alveoli is filled with pus. अब इस alveoli के अंदर अगर pus होगा या पानी होगा तो ये surfactant धुल जाएगा. नहीं तो even in neonates we have this that who are preterm neonates जिनकी जन्म 34 weeks से पहले हुआ है, we know that the lung is not mature enough to produce the surfactant. So in all of these cases, either it is a neonate who has been born preterm due to deficiency of surfactant, or due to the destruction of surfactant when the alveoli is filled with fluid, pus or blood, what tends to happen is these diseased alveoli will start getting pitched out. ठीक है, ऐसे पिचक गया. Now, tell me which of these two balloons is easier to inflate? Is this balloon easier to inflate, the yellow one or the green one which is pitched out? ये मेरा एक alveoli है, ये दूसरा alveoli है जो बंद हो पड़ा है. Which one is easier to inflate? Exactly, the yellow one is easier to inflate. Correct? Which means that whenever there is a defect of oxygenation and it is due to a shunt formation, wherein the diseased alveoli numbers are so high that they have started to get collapsed. What is the only way that I can improve the oxygenation in these alveoli? The only way that I can improve the oxygenation in these alveoli is, number one, of course, I will have to give antibiotics for the pneumonia. Of course, I will have to give diuretics like Lasix or Ditor for the pulmonary edema. But my first target is ये जो alveoli pitched out हुआ है, इन pitched out alveoli को थोड़े से खोलने होंगे. For this, we will need to give an additional pressure from outside. That pressure is called the PEEP. PEEP, that is the concept of positive end expiratory pressure. Now, I am going to show you PEEP in the bigger balloon, which you can see now. Consider this to be a normal alveoli. ये हो गया alveoli का inspiration. Now, this is alveoli ka expiration. Now, clearly see, in the process of expiration, I did not completely deflate this alveoli. Can you all see this? कि ये पिचकाऊ हुआ नहीं है. Can you all appreciate this, that this alveoli has not gone back to its original shape? It was inflated, but when it started getting deflated, it has come to this position and stopped. ये पिचकावा हुआ नहीं है. There is still quite amount of tension in these walls. Now tell me, because we know this is a healthy alveoli, और इसमें पूरा सा it did not get pitched out or collapsed, it is easier to inflate this alveoli in the next breath. Like, just see how beautifully and easily I could inflate this alveoli. Again, it became, there is a process of expiration. It has still not closed completely. Again, I will find it easier to inflate it. Next cycle of expiration, again, it has not closed completely. Easier to inflate. Versus if this alveoli became completely pitched out like this, now it is very, very difficult to keep this alveoli open for the next cycle of breath. So, coming to the summary of this entire Ramayan Katha that I said, in a problem of oxygenation, either I can have one case where FiO2 कम है या फिर atmospheric pressure कम है, which I can acquire in higher altitudes. But if all of these are fine, यानी कि FiO2 सही है, atmospheric pressure भी normal है, patient ICU में वेंटी पे है, फिर भी ऑक्सीजनेशन का डिफेक्ट हो रहा है, it is because these alveoli have become into shunts. यानी कि these alveoli cannot take part in oxygenation or gaseous exchange anymore. To prevent this shunt formation, along with treating the primary pathology, be it antibiotics for pneumonia or diuretics for pulmonary edema, my target is to keep the alveoli, prevent the alveoli rather, from collapsing entirely during expiration. Which means I have to induce a certain amount of pressure. See, this is alveoli inspirating. Whenever it tries to get pitched out during expiration, it is trying to get pitched out right at this point. I will have to provide a certain pressure so that the alveoli will not become like this, but will rather stay like this, so that I can inflate it again in the next cycle. Is this clear to anyone, everyone? This amount of pressure that I am providing as a positive pressure from outside, right at the end of expiration, right at the end of expiration, so that the alveolar walls don't collapse, is known as the positive end expiratory pressure or PEEP. Is this clear to everyone? ठीक है. आज से पहले कितने लोगों को पीप का कॉन्सेप्ट पता नहीं था? आज से पहले कितने लोगों को पीप का कॉन्सेप्ट पता नहीं था? कितने लोगों को पीप का कॉन्सेप्ट पता नहीं था? पीप सुनते ही यू स्टार्टेड टू पीप. भाई क्या बोल रहा है पीप? ओके, वेरी गुड. इज इट क्लियर नाउ? Is it clear now? Dr. Sabya, everyone else, not able to read all of your names, but I'm trying. Okay, Dr. Gladys George, everyone. So, what is PEEP? It is a positive end expiratory pressure that I am going to give at the end of expiration, so that the alveoli remain in a partially open state. Am I clear? The alveoli remain in a partially open state because a partially open alveoli is easier to inflate again. Am I clear? So, short, what is oxygenation? Amount of oxygen that is entering into the patient. If there is a defect in oxygenation, what can I do? मानो पेशेंट फेस मास्क पे है, फिर भी पेशेंट डिसैचुरेट कर रहा है, आई विल एस्केलेट इनटू अ एनआरबीएम. फिर भी डिसैचुरेट कर रहा है, आई विल गिव एचएफएनसी. फिर भी डिसैचुरेट कर रहा है, मैं वेंटिलेटर पे डालूंगा. व्हाट एम आई डूइंग इन ऑल दीस फोर डिवाइसेस? आई एम इंक्रीजिंग द FiO2, दैट इज द अमाउंट ऑफ ऑक्सीजन दैट इज डिलीवर्ड. करेक्ट? सो इफ अ पेशेंट हैज अ ऑक्सीजनेशन डिफेक्ट, my first thing that I can do is increase the FiO2. But there is only a certain point till which I can increase an FiO2. 100 से ज्यादा तो मैं FiO2 कर नहीं पाऊंगा. So if I am increasing it till 100%, still the patient is having an oxygenation defect. It is because this patient is having the alveoli which are working as shunts. So my work is to recruit the alveoli. This is where I will use a technical term. Till now I was talking in simple terms. Now I'll be using a technical term. This is my time when I will recruit the alveoli. बोलूंगा कि भाई ठीक है, मैं मानता हूँ 70% alveoli तुम में पस भरा हुआ है, लेकिन ऐसे पिचक मत जाओ, थोड़ा खुल के रखो ताकि मैं एंटीबायोटिक देके पस भी निकाल पाऊंगा. At the same point of time, your walls will not be collapsed. क्योंकि अगर आपका वॉल बंद हो गया तो इसे खोलने में मुझे जितना वक्त लगेगा और जितना एनर्जी या जितना वर्क ऑफ ब्रीदिंग लगेगा, I will be tired. So the ventilator's work is not just to give you an FiO2, but also to maintain a PEEP so that your work of breathing is lowered. Can I therefore call this as a method or a phenomenon of alveolar recruitment? Can I say that? Everyone, thumbs up. So oxygenation defects, क्या करूंगा? Number one, try increasing FiO2. You can only increase it till a certain point of time. Once you have reached that certain point, still the patient is having hypoxia or hypoxemia or an oxygenation defect, whatever you may call, you will try to increase the PEEP because PEEP is going to recruit the alveoli. Now, a question to all of you. Can you tell me one outpatient method या फिर a method that we use in the general ward या फिर घर में भी patients को हम लोग बोलते हैं, a method in which we can cause a similar phenomenon of alveolar recruitment? Can you tell me what is that name of the method? आप घर पे पेशेंट को तो पीप नहीं दे पाओगे, जनरल वार्ड पे पेशेंट को पीप नहीं दे पाओगे. What is the method that we use in order to create a similar, mimic a similar phenomenon of alveolar recruitment that is done in home settings, that is done in general ward settings? क्या देते हैं हम लोग? अम्बू. घर पे किसको अम्बू दिए हो? डॉक्टर अपेक्षित, when do you give अम्बू at home, dear? नो 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 नो. भाई सिंपल सोचो. आप लोग सब वेंटिलेटर के क्लास में वेंटिलेटर बड़ा बड़ा करके सोच रहे हो, बड़ा करके मत सोचो. Nebulization? No, not really. Not really. Valsalva? No, no. Yes, I have finally got the answer from Dr. Gladys George. A big hand to you. शाबाश. So देखो, इतना मैं बहुत सिंपल सवाल पूछूंगा, कोई बड़ा चीज नहीं है, सिंपल सी, धीरे धीरे जाएंगे हम लोग. So one method that we will be using in order to mimic another environment of recruitment is what we call as incentive spirometry. कोविड के वक्त कितने लोगों ने देखा है रॉमसन का 3 बॉल स्पाइरोमीटर करके खींचते हैं, तीनों बॉल उठता है, रेड बॉल, ग्रीन बॉल, येलो बॉल. हाउ मेनी ऑफ यू हैव डन द इंसेंटिव स्पाइरोमेट्री? पेशेंट्स को एडवाइस किए हो, या फिर एनेस्थीसिया में जो लोग काम किए हो, या फिर ओटी में जो लोग काम किए हो, यू हैव टोल्ड द पेशेंट कि देखिए बाबा आज आपका ओटी हुआ है, कल से बॉल उठाइए, अच्छे से तेजी से बॉल उठाना है, 3 बॉल उठना चाहिए वरना डिस्चार्ज नहीं करेंगे, बोले हो, राइट? वेरी गुड. सो दैट इज एग्जैक्टली व्हाट यू आर डूइंग. यू आर मिमिकिंग अ सिमिलर मेथड, बट डिफरेंस क्या है? इन आवर नॉर्मल ब्रीदिंग, inspiration is due to negative intrathoracic pressure, but ventilation is a method of positive airway pressure. यानी कि इस बलून को अगर मुझे फुलाना पड़ रहा है तो I am having to give pressure from outside. ये जो मेरे गाल फूल रहे हैं, दिस इज द पॉजिटिव एयरवे प्रेशर दैट आई एम गिविंग. बट जब एक इंसान कॉन्शियस होता है, व्हेन द पर्सन इज टेकिंग ब्रेथ्स ऑल बाय हिमसेल्फ और हरसेल्फ, व्हाट वी टेंड टू डू इज अ नेगेटिव सक्शन प्रेशर, क्योंकि सक्शन इज व्हाट लीड्स टू इंस्पिरेशन, है ना? सो सक्शन करेंगे तभी इंस्पिरेशन हो पाएगा. सो वी टेल दैट पेशेंट की करके 3 बॉल उठाने की कोशिश करो टू मेंटेन अ सर्टेन अमाउंट ऑफ प्रेशर, so that will be keeping your airways open, alveoli open. Can I say that? So can I sum up, everyone in the chat? Can we all write yes if I am correct that whenever there is an oxygenation defect, number 1, try improving FiO2. Number 2, try giving PEEP so that the alveoli are recruited. Number 3, for maintaining the patient, try doing incentive spirometry. Is everyone clear with this? सारे बच्चे clear है? Very good. शाबाश. चलो. So, Dr. Rimjim, can you show us the 2 common problems in life ka slide, focusing on the one problem that we have already done? Okay, Dr. Rimjim is saying I'm going to play the animation again. Chalo, koi baat nahi.
Okay, I'm really sorry. I do not know why it's not happening.
Koi baat nahi. Jamil is tired.
Can anyone help?
We can move to the next slide.
Okay.
We will bring Jamil Chacha back. Yeah, thank you so much. Okay, so FiO2 and PEEP का concept clear है सबको? Very good. Now, what is ventilation? Ventilation and oxygenation is not the same. Now, oxygenation का मतलब क्या था? The amount and the phenomenon of taking in oxygen into my lung. What is ventilation? Ventilation is this entire process of gaseous exchange where oxygen is diffusing from the alveoli to the pulmonary capillary and carbon dioxide is diffusing out from the pulmonary capillary to the alveolus and finally expired out of the body. So the entire process of gaseous exchange is what we call as ventilation. Do you now realize that whenever I talk of ventilation, the major gas that I'm going to talk of is carbon dioxide. That is the major gas that I'm going to talk of, carbon dioxide. Okay? So when I talk of carbon dioxide, we also have a parameter in before I talk of parameters, can you tell me what are the parameters in the monitor through which you can understand whether the patient is well oxygenated or not? कौन से चीज को मॉनिटर पे देखने से आपको पता चलेगी कि पेशेंट की ऑक्सीजन लेवल सही चल रही है? एवरीवन, SpO2, शाबाश डॉक्टर शान, SpO2 एक हो गया, SpO2 नंबर टू SpO2 एक हो गया, ओके वन डन SpO2 नंबर टू, सिर्फ SpO2 से नहीं बाबा, और आगे बढ़ो, रेस्पिरेटरी रेट, अच्छा ठीक है चलो टेकन रेस्पिरेटरी रेट, BP, hypoxia, yeah, hypoxia can cause hypotension. I am not going into that. What I am saying is, yeah, heart rate. That's perfectly correct. Heart rate. Okay. Something else. ABG. What do we see in ABG? Twinkle. What do we see in ABG? Twinkle. Dr. Twinkle. ABG में क्या देखेंगे बेटा? Yeah. So we are going to see PaO2. Correct. So PaO2, heart rate, and SpO2. These are the three things that I can see to call something as an oxygenation defect, whether there is an oxygenation defect or not. But when I talk of ventilation defect, मेरे पास CO2 measure करने के लिए कुछ नहीं है. Yes, in some high-end machines, I do have a feature called the ET-CO2 or the end-tidal CO2, but हर एक ventilator पे ET-CO2 का measurement possible नहीं होता. Right? So the only parameter that can help me guide about the carbon dioxide levels in the blood is PaCO2, and that is solely going to be done by the invasive technique called ABG, that is arterial blood gas analysis. Okay? So anytime I'm talking of ventilation, I'm predominantly meaning about PaCO2. Now, whenever the CO2 is going to rise in your body, do you start understanding this, that this is going to be a problem because it will lead to something called respiratory acidosis? कितने लोगों ने मेरे ABG का session attend किए थे? How many of you have attended my ABG session that I took? That is why I'm taking these topics in sequence. क्योंकि मैंने पहले ABG करवाया and then I'm doing the ventilator. So the ones who have not done my ABG session, it is a request, it's an honest request to you. Please go to YouTube. Mediversal has its sessions, streamed. So you can look at the ABG session. Whenever there is PCO2, which is rising in the blood, it is going to lead to something called respiratory acidosis. Correct? Now, the problem that will start arising with respiratory acidosis is, number one, it will start depressing the respiratory center. Whenever there is a depression of the respiratory center, that will lead to bradypnea or apnea. It will also at some point of time lead to hypotension and bradycardia, which can further precipitate a cardiac arrest. So my only method in order to treat a ventilatory defect is going to be to wash out this CO2. Correct? अब बात ये आती है, how do I wash this CO2 out? My washing out of CO2 will be determined by something which is known as the concept of minute ventilation. What is minute ventilation? It is simply a product of tidal volume into respiratory rate. Okay? For example, in a normal breath, we take 500 ml of air. No, not just increasing respiratory rate. So this is the problem. I knew you would just say respiratory rate, but हमेशा सिर्फ respiratory rate बढ़ाने से नहीं. आप कितना बढ़ा पाओगे respiratory rate? 30, 35, उससे ज्यादा तेज तो आप सांस भी नहीं ले पाओगे. So you will also have to increase the tidal volume, my dear. है ना? So tidal volume into respiratory rate, this concept is called the minute ventilation. The minute ventilation is what is going to determine the amount of CO2 washout that we need to be doing. Normally हम ये बोलते हैं that minute ventilation is supposed to be 1/10 of your ideal body weight. यानी कि if I take a 60 kg man, then the minute ventilation should be around 6 liters. 6 liter बोले तो 6000 ml. So can I say that if I set maybe say a tidal volume of 500 ml and I give a respiratory rate of 12, then the product 500 into 12 is going to come out as 6000 ml or 6 liters. What is tidal volume? The amount of air that is going in and out of the lung in one cycle of respiration. That is what is tidal volume. The amount of air going in and out of the lung in one breath is called tidal volume. When I multiply it by the respiratory rate, I get a product which is called the minute ventilation. And in the minute ventilation, this minute ventilation is what is going to decide the amount of CO2 washout that will happen. Itna clear hai? Everyone is working. So we have discussed two common problems in life: oxygenation, ventilation. Jinka common solution ek hi hai, the idiot, that is the ventilator. Now, ventilator FiO2 बढ़ा सकता है, that will improve oxygenation. Ventilator PEEP बढ़ा सकता है, that will cause alveolar recruitment and improve oxygenation. Ventilator minute ventilation को set कर सकता है by us setting a prerequisite respiratory rate and a tidal volume, जिससे minute ventilation को हम लोग regulate कर सकते हैं, and that will be helping us in CO2 washout. Can I therefore prove that two common problems in life have one solution, that is the ventilator? Can I prove that? Everyone in sync with me? सारे बच्चे एक साथ? Very good, very good. शाबाश. चलो, let's move to the next slide. ठीक है? Let's move to the next slide. चलो. So, as I said, the ventilator's predominant method of working is to reduce the work of breathing. Now, how does it reduce the work of breathing? Everywhere we read this one line in textbook: ventilator reduces work of breathing. अरे भाई, ये work of breathing है क्या? So whenever I'm taking in air, do you understand this air is passing through my nose, then through the nasopharynx, then through the oropharynx, and then it is going through the laryngopharynx. In the laryngopharynx also, it is dividing from the trachea to the bronchi to the bronchioles and then going to the alveoli. Which means that whenever I am going to take in air through the normal spontaneous breathing mechanisms, there is always a certain resistance that is being acquired, because the air is moving from the nose to the nasopharynx and down and up till the tracheobronchial tree. The diameter of these areas start getting narrowed. And we always know that resistance that is offered by a structure is inversely proportional to the fourth power of radius. Everyone knows this? Resistance offered by a structure is inversely proportional to the fourth power of radius. यानी कि दो pipe है. If this is one pipe, say if this is one pipe and this is another pipe, in दोनों pipes में से which of the pipes will have lower resistance? Will my AC का remote have lower resistance, or will my pen have lower resistance? Whose diameter is smaller? इसका diameter smaller है, so इसका resistance बहुत 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 high होगा. So the AC remote will be having a lower resistance. Do you now realize जब हवा from the trachea to the bronchi, bronchioles, everywhere, as it is going down the generations of the tracheobronchial tree, the diameter of this entire system is getting reduced. Whenever the diameter is getting reduced, fourth power of the diameter gives value of resistance. So जितना diameter घटेगा, resistance will increase that much. So in a patient who is sick, in a patient who is unconscious, in a patient who has an impending airway compromise, we have to reduce the work of breathing. What a ventilator does is you intubate the patient, and I'm predominantly talking of mechanical ventilation. ठीक है, आज की पूरी क्लास में हम लोग मैकेनिकल वेंटिलेशन पे ही बात करेंगे. हम लोग बाईपैप सीपैप पे बात नहीं करेंगे. एज आई सेड, आज की क्लास के लिए वो बहुत ऊपर से जाएगी. हाँ, तो हम लोग बहुत बेसिक्स पे बात करेंगे, एंड वी विल ट्राई टू मेक आवर बेसिक्स स्ट्रॉन्ग, सो दैट इसके ऊपर वी कैन स्टडी मोर एंड वी कैन टेक मोर वेबिनार्स ऑन वेंटिलेटर. ठीक है बेटा? सो एज आई एम सेइंग कि my predominant work is going to ensure that whenever I intubate a patient and I put a tube, this tube is directly put into the trachea. Correct? सब agree करते हैं? Anyone who has intubated a patient? कितने लोगों ने intubate किया है? ICU में काम कर रहे हो, जितने लोगों ने intubate किया है, चलो अपने अपने हाथ खड़े करो. सारे बच्चे who have intubated till now? Yes, very good. Dr. Shashi, very good. Dr. Twinkle, yes, very good. Who else have intubated? Dr. Vikrant, shabash, very good. Claps to all of you. Okay, this is one of the best things. I'm very sure जब आपने लाइफ की पहली इंट्यूबेशन की थी, जो खुशी महसूस हुई थी, वो बहुत उम्दा लेवल की खुशी है. राइट? सो द वंस हु हैव नॉट डन, you will be doing it very soon. ठीक है? So whenever you intubate a patient, you see the vocal cords and you directly place the tube into the trachea, which means you're bypassing this entire level of nose, nasopharynx and everything, and directly putting the tube into the trachea, directly delivering that FiO2 directly into the trachea, which is why you're reducing the work of breathing by bypassing the upper airway. But फिर मेरे को एक सवाल करना बनता है कि अगर ऐसा ही होता, then universe, God, जो भी आप मानते हो, would have not created this nose and nasopharynx. Can you tell me a disadvantage or a negative effect that we encounter due to bypassing this upper airway? हम लोग normal spontaneous breath पे we are taking air that is moving in through the nose and the nasopharynx and the upper airway and finally reaching the last levels of the tracheobronchial tree. Correct? what is the disadvantage when I'm ventilating a patient and ventilating the patient for a very long time? That is the hint that I'm giving you. बहुत देर तक patient को मैं ventilate रख रहा हूँ for a chronically long period. Yes, somebody is saying, Dr. Apekshit is saying high. Yes, Sneha, very good. Okay, so Sneha happens to be one of the most junior most doctors that we have. Thank you so much for joining in. So yeah, so Dr. Sneha, can you turn your mic on? Vijay sir, can we allow Sneha to turn her mic on? I'm very happy when juniors come up and speak such good answers.
Done. They can
Sneha?
unmute and they can talk.
Sneha, you can unmute yourself. Can you please talk about this humidification factor that you said, beta?
Hello, Dada.
Yeah, hi. Please tell me about the humidification that you talked of.
Actually, in nasopharynx, the natural function of nasopharynx is to humidify the air that we are taking in.
Shabash.
When we are placing a ventilator, we are actually bypassing the entire airway. So
perfect. So the air that is directly reaching into the trachea is basically a dry form of air. But उससे problem क्या होगा? What is the problem that we will encounter?
So there will be lung injury.
Absolutely. There is a chance of lung injury, number one. Number two, that will start happening is not just, Sneha, not just is the upper airway, supposed to humidify your air, but it is also supposed to remove the foreign allergens and dust particles. That is by the beating movement of the cilia. Correct, accepted. Whenever you are chronically and for a prolonged time ventilating a patient and directly delivering that dry amount of air into the, the lungs, that upper airways function of protection that is giving you an innate immunity that is completely gone. That predisposes the patient to infections. Is that clear? Clear? Everyone's clear with it? Good. Thank you. Okay, you can turn your mic off. We'll be telling someone to join in always. Okay. So the cilia is not able to work. So anytime we are bypassing the upper airway, we are always increasing the risk of infections, and we are also leading to something which is called epithelial damage due to the dryness of the air. This dry air that is going to come, that is significantly potent enough to cause epithelial damage of the alveoli and thereby causing disruption further in the alveolo-capillary membrane. Okay? Okay. Now, what is work of breathing affected by? Now, here comes another important and a favorite physiology topic of mine. We will study about what is called the compliance. Now, what is compliance? Let's get back to our favorite balloon. Okay, so I've got a bigger balloon so that it's easier for you to understand now. Can you see that this balloon is distended? सबको दिख रहा है? Balloon is distended. The amount of distensibility of a structure when ventilator is pushing in the air, that is known as compliance. सबको याद रहेगा? C for compliance means D for distensibility. C for compliance means D for distensibility. यानी कि जो स्ट्रक्चर जितना compliant वो उतना ज्यादा फूलेगा. अब लंग्स में फूलने वाला स्ट्रक्चर तो भाई एक ही है, that is the alveoli. So do you want a good compliant lung or a bad compliant lung? Everyone? Ideally, we want a good compliant lung or a bad compliant lung? We all want a good compliant lung. ताकि हम जब हवा ले, चाहे वो spontaneous breath से हो या ventilator के द्वारा हो, the alveoli should open up well. Correct? And do you realize that whenever a good compliant alveoli is there, it will not just open up well, but it will also maintain a certain pressure. It will maintain a certain tension in its walls. Correct? Now, अगर यही बात होती, then I can clearly say कि इस लंग को फुलाते जाओ. Now I am giving you an experimentation. हालांकि मैं नहीं करूंगा, फट जाएगा, and I do not have other balloons. इतना तक मैं फुला सकता हूं. अब इसके बाद when I try to inflate this balloon, I am running a risk of rupture of this balloon. This also explains two concepts. Number one, मेरी जितनी मर्जी tidal volume push करता रहना is wrong. So I will have to maintain a certain tidal volume whenever I've kept a patient on the ventilator, because I will have to know that this lung is injured. अरे भाई sick lung है, that is why I'm ventilating. Normal lung को कौन ventilate करता है? So an injured lung is like a baby. Balloon फूल सकता है लेकिन उसकी एक लिमिट है. I cannot keep pushing whatever amount of air that I want into this balloon, because after a point of time, no matter how good and how well compliant this is, it will burst, which means excessive tidal volume given to a patient can lead to volute trauma. So that's first concept. That is why we are always going to maintain the tidal volume between 4 to 6 ml per kg of ideal body weight. Ideal body weight का concept मैं थोड़ी देर बाद बात करूंगा. First concept is tidal volume should be maintained between 4 to 6 ml per kg of ideal body weight. First. Second concept, what is compliance? It is the distensibility of a structure. But कंप्लायंस का मतलब ये नहीं है कि जितना मर्जी चाहे वो कंप्लायंट हो, डिस्टेंसिबल हो, बिकॉज आफ्टर अ पॉइंट ऑफ टाइम देयर विल बी इंजरी दैट विल बी हैपनिंग, देयर विल बी वॉल्यूम ट्रॉमा, देयर विल बी रप्चर ऑफ द एल्वियोलर वॉल्स, which means leads us to a point nothing of too much in life is good. Good compliance is what we need, but overtly good compliance is bad. Overtly good compliance is bad. Why? Let us talk of a disease which is called emphysema. In emphysema, what is the problem? The problem is not in inflation. The lungs are brilliantly compliant. In fact, अगर ये एक emphysematous lung है, this is an emphysematous lung. बस यही प्रॉब्लम है कि इसके बाद whenever the time for expiration comes, it cannot release the air because the opposing force to compliance क्या है? Distension. What is the opposing force to compliance? It is called elastance. What is elastance? It is the ability of a structure to recoil. Normally, for a normal, spontaneous, good respiration, as I said, the alveoli should open and the alveoli should close, but not completely close. So, ऐसा होना चाहिए. But ये जो opening है, that is determined by compliance. So, a structure which is well compliant will open easily, but it also should know how to recoil back. And this recoil is what we call as elastance. In emphysema, due to the protease anti-protease disbalance and whatever things happen, we know it in pathology, there is a problem due to loss of elastin fibers. Due to this loss of elastin fibers, elastance grossly decreases, which means an emphysematous lung, you will find it very hyperinflated. Can you all agree? How many of you have seen the chest x-ray of an emphysema patient? Haven't you seen something which is called a barrel-shaped chest with hyperinflation? Everyone? Twinkle? Very good. Yes. So you have seen hyperinflation. What does it mean? कि वो फुल तो चुका है, but वो बंद नहीं हो पा रहा है. Because compliance is so high that elastance does not come into picture. Because of this loss of elastance, this lung doesn't know how to throw out the air, which means there is significant areas of air trapping. And these areas of air trapping is what we could call as bulla. These are the areas that we call as bulla, B-U-L-L-A. ठीक है? So, compliance अच्छी है, because good compliance will mean I can distend the lung more. Can you tell me a condition where the compliance is affected? Anyone? Something that we see very commonly in ICU patients. Compliance की difficulty, भाई lung full ही नहीं रही है. Stiff lung बोलते हैं. ARDS, very good. Anything more? Anything more? Chalo, let's take the common. Yeah, ILD. Very good. Very good. Shabash. So let's take the common example. कि ARDS है ILD. Lung फुलता ही नहीं है भाई. So when the lung is not expanding, यानी कि the problem is with compliance. But too much compliance is bad. क्योंकि compliance अच्छा है, but उसको वापस भी तो आना है. If it cannot come back, if there is loss of elastance, as it is seen in emphysema, the air will start getting trapped. And in these patients, what is the air that is getting trapped now? It is the carbon dioxide rich air, which means you have significant areas of air trapping and a high PaCO2 levels. Does that explain why the emphysematous patients come with type 2 respiratory failure where there is a high PaCO2? Because of these significantly large areas of air trapping. Is this clear? Perfect. Good job. Okay. So we talked of low compliance, we talked of high compliance, we talked of the fact that compliance is inversely proportional to elastance, and for an ideal lung, it should have a good compliance and also a good elastance. And it is the balance between these two factors, compliance and elastance, that is going to lead to a good lung. Chalo, एक out of the question, out of the slide question. सारी चीजें मैं slide पे नहीं डालूंगा. What is the volume? That is the equilibrium volume between this point of compliance and elastance. I want the answer in the chat. सबको lung volume और capacity पता है, PV, IRV, ERV सब चीजें पता है आपको. I want to know what is ये जो मैं इसको फुला रहा हूं, compliance. ये हो गई compliance. अब धीरे धीरे It is getting pitched out. ये elastance की वजह से हो रहा है. Now, what is this volume that is there? What is this volume that is there? What is the equilibrium volume? No. PEEP, Babu, PEEP is the pressure. I am talking of what is the equilibrium volume between when a structure is compliant and a structure is having a good elastance. What is the equilibrium volume of the lung known as? FRC. Yes, it is FRC. Absolutely, it is FRC. Very good. It is the functional residual capacity that is also known as the equilibrium volume of the lung. शाबाश. चलो यार, आप लोग तो बहुत अच्छे हो. Very good. You all are very, very good. Okay. So we have done all of this. चलो, let's move to the next slide. Dr. MJ, have we fixed Jamil Mama? थोड़ा चला दो, आपके बहुत मन कर रहा था आपको. देख लेते हैं. चलो. After every topic, we will try playing Jamil Mama a bit. I think you need to remove the laser pointer for Jamil Mama to work. Yeah, see.
अच्छा तू मेरा चला तो रिसेट कर रहा हूं.
शाबाश. चलो. Okay. Cheers. Let's move to the next topic then. चलो आगे बढ़ते हैं. शाबाश. Now comes to modes of ventilation. देखो भाई, when you read textbooks, you will find a lot of modes. ठीक है. बट प्रैक्टिकली मैं बोलूं तो पूरी जिंदगी में आपको सिर्फ 5 मोड ही काम आएंगे. आप इसके अलावा बहुत सारे मोड्स आपको चैट जीपीटी बता देगा, टेक्स्ट बुक्स बता देंगे, थियोरेटिकली एग्जाम्स में लिखने पड़ेंगे, बट उन सब एक मोड का भी काम नहीं आता है. पिछले 3 साल से व्हेन आई वर्कड इन क्रिटिकल केयर, आई हैव ओनली यूज्ड 5 मोड्स. अगले 30 साल ऑल्सो इफ आई वर्क इन क्रिटिकल केयर, आई विल बी ओनली यूजिंग दीज 5 मोड्स. इस 5 से ज्यादा मोड्स जरूरत नहीं पड़ेंगे. तो आई विल ओनली बी टॉकिंग ऑफ दीज 5 मोड्स. एज आई सेड, दिस क्लास इज मोर ऑफ अ प्रैक्टिकल क्लास, जहां पे आई विल बी टॉकिंग ऑफ प्रैक्टिकल सिनेरियोस, नॉट गोइंग टू गो इनटू थियोरेटिकल कॉन्सेप्ट्स. ठीक है. सो 5 मोड्स है मेरे पास. VC-ACMV, PC-ACMV, PSV, VC-SIMV एंड PC-SIMV. कितने लोगों को ये सारे मोड्स के नाम सुनने के बाद दिमाग में चक्कर आ रहे? थम्स अप. कि भाई सुना सुना लग रहा है, बट कहां सुने हैं पता नहीं है, याद नहीं रख पाते. Okay, good. Twinkle, you have been working in the ICU. I can understand. Chalo, let me see if I can make this easy. So this is Jamil Mamu for you here. Chalo, move on with the slide. Dr. Nimjam? Yeah, shabash. So I will compare ventilation modes to a scenario that we often encounter in a driving school. कितने लोगों को ड्राइविंग आती है? 4-wheeler की ड्राइविंग, and they have learned it from a driving school. कितने लोगों को ड्राइविंग आती है and they have learned it from a driving school? Very good. Dr. Gladys George. Okay, sure. Okay. Dr. Sabia, everyone. Okay. So one common scenario that you will be encountering in the driving school is they have got some different cars. कभी-कभी हाँ, हर जगह पे नहीं मिलता है, but कभी-कभी you will find some driving schools having a set of specialized cars. उनमें 2 steerings भी होती है. ठीक है. So in these driving schools, the fun fact is कि even you can drive. Sometimes the trainer can also drive. And sometimes, if you are very confident, of course, you will be shifted to a car which is like a normal car, and there will be only one steering wheel for you to drive. So we'll be just comparing this entire situation of these modes to what we find in a driving school. Okay. Before we decide what is the mode of a ventilator, we have 2 questions to address. First, how will you fill the car का टायर? भाई कार चलाओगे तो पहले तो देखना होगा कि कार के टायर में हवा है कि नहीं, है ना? So your first question is, how will you fill the tire? Will you be using a pressure control to fill the tire, or will you be using a volume control to fill the tire? The second question is, भाई गाड़ी कौन चलाएगा? क्योंकि when you have not learnt a ABC of driving, you will be sitting and the trainer will be first driving and showing you कि बेटा देखो गाड़ी ऐसे चलाई जाती है. So the first question is, भाई गाड़ी कौन चलाएगा? ट्रेनर गाड़ी चलाएगी कि आप गाड़ी चलाओगे, या फिर दोनों मिलकर गाड़ी चलाएंगे? यानी कि कभी कभी ट्रेनर भी चला रहा है, कभी कभी आप भी चला रहे हैं. Trust me, these 2 set of questions and these questionnaires will exactly tell you how to imagine a ventilator mode. Let us go into it slowly. Okay. Now, I will first talk of how will you fill the tire. So, is there anything more on this slide, Dr. Nimjan? Do we have anything more on this slide? Yeah. Okay. ठीक है. इसको हम हटा देते हैं for a while. I mean, हटा देते हैं in the sense, let's go back. पीछे चले जाते. Yeah, lovely. Okay. let's show me the second diagram that is there. Perfect, great. Okay, so how will you fill the tire? That's the first question. So I have two options. Mano, this is my Garika tire, and I will be using the same analogy of tire to alveoli or balloon, whatever you call. ये है मेरी गाड़ी का tire. How many of you have ever gone to a pump station to fill your tire with हवा? कितने लोग गए हो या फिर देखे हो लोगों को गाड़ी में हवा भरते हुए टायर में? Okay, good. So some of you have. So you will find या तो हम जाके ये बोलते हैं कि भैया 1 लीटर हवा भर दो या टायर में, या तो ये बोलते हैं, नहीं तो ये बोलते हैं कि भैया देखोगे यू विल ऑलवेज फाइंड कि दे हैव अ गेज मीटर, एक क्लॉक जैसा होता है कि अलार्म क्लॉक, दे पुट इट ऑन द टायर एंड दे पुश 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 करते हैं एंड वी चेक कि टायर में प्रेशर कितना है. सो आइदर वी टेल देम कि देखो टायर में फिलहाल 10 psi का प्रेशर है, आप उसको 30 psi तक कर दो, मेक द प्रेशर 30 psi. यस,
There has been a message to kindly request you to talk in English because some of the audience cannot understand Hindi.
okay, so number one, I am predominantly talking in English. I am repeating certain things in Hindi only when it needs to be, talked regarding a humor or a joke, because certain jokes, of course, I will not be able to translate in English because it will kill off the mood. But I will still try to stick to English. There are some times when I am forced to use Hindi to keep the mojo of the session alive. Okay. So there are predominantly two modes in a ventilator. Two things that I need to consider. The first thing is how will I be filling up the tire? If I go to a tire pumping station, jahan pe, the tire is being inflated, my first question that I will be asking is, how do you want to fill up the tire? Do you want, either I can say ki, brother, please give 1 liter of air so that this tire gets inflated. I do not care what pressure you give, but give 1 liter of air. Or I can say, keep the tire pressure to 20 psi. No matter how much volume you give, I don't care. Is this clear with everyone? Either I can say, give 30 psi or 20 psi and inflate the tire. I do not mind कि अगर 20 psi generates 200 liters of air or 2 liters of air, I don't care. Just make sure that the tire is having a pressure of 20 psi. Either I can say this, or I can say कि भैया please add 200 ml or 200 liters of air to the tire. Which means at one point of time, I can only control one parameter. Ya to I can control pressure and the volume will be independent, or I cannot control, or I can control volume and the pressure will be independent. Let us understand it with the example of the balloon. Suppose this is the car ka tire and this person has come to me and said, ki brother, please fill this up with 20 ml of air. Okay, so I will be giving 20 ml of air. हो गया 20 ml air. Suppose this is another person has come to me with a smaller size tire. Do you understand that if I give 20 ml of air to this balloon and 20 ml of air to this balloon, although the volume of air is still the same, but the pressures may be different? Are you getting this? This was a larger balloon. Is everyone clear? Let me inflate this balloon and show you as well. Okay, so this is so again, I'm showing you how difficult it is to inflate a balloon which is smaller and narrower. In order to put 20 ml of pressure into this balloon, it was generating so much, 20 ml of volume to inflate this balloon. It was generating so much amount of pressure that it literally slipped out of my lips. But to generate 20 ml of volume in this balloon, the pressure that was generated was not so high. It is still there in my hands, which means either I can set the mode of a ventilator to a volume control method where I am telling the ventilator, you will give 400 ml of air in each tidal breath. Whether that generates 15 psi pressure, 20 psi pressure, or 30 psi pressure is not my concern. Either I can say that, or I can say that you will be given 15 psi pressure. Whether that 15 psi pressure will generate 200 ml tidal volume or 600 ml tidal volume is not my concern. Which means I can only control one parameter. Ya to I can control volume or I can control pressure. Is this clear with everyone? Is this clear with everyone? If not, I will have to give another example. Is this clear for everyone? let us try to see another analogy. Can you tell me with your common sense? Okay, suppose I am trying to maintain a volume control inflation. On one hand, I have a Swift Desire ka tire. On the other hand, I have a truck ka tire. Okay? Truck has a bigger tire. Swift Desire ka chota sa tire. Okay? I have gone to the air pumping station and I have said, ki bhaiya, please make sure that the tires are full. So the person asks, how do you want me to inflate? Do you want me to inflate using a fixed volume or a fixed pressure? So I say, ki, okay, make sure that you are giving 500 ml of air to the truck ka tire and the Swift Desire ka tire. So this person pumps 500 ml into the Swift Desire ka tire, 500 ml into the truck ka tire. Can you tell me which tire will have more pressure? 500 ml of air into truck ka tire is basically nothing because the truck tire is so large. It will not be having a sustained pressure. So the pressure generated in a truck ka tire with 500 ml is going to be very, very less. But Swift Desire ka tire will be highly inflated and highly tense. So it clearly means I have only control on one parameter. Either I will control the volume, I cannot control the pressure, or I will control the pressure. Yani ki I go and tell this person, ki bhaiya, please generate a pressure of 60 psi in both the Swift Desire and the truck, which means 60 psi pressure say I will be able to inflate both the tires. But of course, when I give a 60 psi pressure to a truck ka tire, it will be having more volume compared to 60 psi pressure on a Swift Desire ka tire. Clear? Everyone's clear with the modes. So the first concept is clear. Ki how will you fill the tire? Pressure ya volume? Okay? Now, second question, who will be driving the car? Okay. Let us come to this point by another analogy where we take in the driving session that is being, the driving class sessions that are being taken. So initially, when you start to learn driving in a driving school, that car is a special car. It has two steerings. So, the first moment, what happens is the trainer starts to ride the car. You are sitting in front of the steering. Aapko lag raha hai that you are driving the car, but you are actually not. You are happy. Okay, I am in the car seat. But the truth is, the trainer is driving the car. The trainer has control of the gear. The trainer has control of when to turn left, when to turn right, how much speed to drive the car. Which means you are simply sitting quietly. The trainer is doing all the work for you. Let us apply this logic on a ventilator. The patient is unconscious. The patient is comatose. The patient is sedated. The patient is apneic. This patient is almost near to death. At this point of time, I want the ventilator to be taking charge of the breaths. So the ventilator will be like, say, every 5 seconds, I will give in a breath. The ventilator will keep doing the work for you. This is what we know as what is the one type of ventilation. What is this type of ventilation? What we will be talking about later. Second scenario, gradually over the next 10-15 days, the trainer starts to trust you. Okay? Trainer starts to trust you a bit and says, ki, theek hai, sit, start driving. Now, the trainer is still controlling you, but he has started to trust you, which means you are the one who is also riding a bit. The trainer is still predominantly in control of the car, but whenever you want to ride, because he has started to be confident with your skills, he is allowing you to drive. But he is still maintaining the car ka motion and everything with his own steering. That is another type of ventilation, which means in the second type, the ventilator is still triggering the breath. The ventilator is still giving a fixed number of breaths that has been set. But if the patient wants to breathe some spontaneous breaths by his own effort, the ventilator is not just allowing, it is also giving full support to it. That is one type of ventilator. The third type is when you have become a pro. So the trainer is like, and you are like, aaj gaddi tera bhai chalayega. Hai na? So you have become Salman Khan. Let's not go further. And you are like, aaj gaddi tera bhai chalayega. So the patient is the one who is driving the car. The trainer is just sitting like this and the trainer is observing. If at all he feels that you will be in some trouble, the trainer is just going to make you aware, but the trainer is not having a steering wheel in front of him. Is this clear? Is this clear to all of you? These are the three situations that we will be encountering in case of a ventilator. Ya to the trainer will drive entirely, you will be sitting in front of your own steering wheel, having the pleasure ki bhai, okay, I am driving, but actually you are not, it's the trainer who is driving. Second scenario is the trainer has started to trust you. He still is maintaining the control of the car, which is own steering, but is also allowing you to move some gears and do some things, and he's entirely supporting you in that activity. The third one is where you are like, aaj gaadi tera bhai chalayega. You are very confident. The trainer is like, I don't need another steering wheel. So you will be the one predominantly driving. I will be the one just supporting you and making you aware of what is ahead. If at all need arises, I will support you. That is the only thing. This, trust me, answering these three questions and whether it's a pressure and volume control answers all the 5 methods of ventilation. Now, I will request Dr. Rimjam to please play the next image. Yeah, fantastic. Okay, I might have to turn my camera off for a while because I am in a bit of pain, which I have been dealing with. So please forgive me for that, but I will keep on speaking. Okay. Okay, so everyone can hear me out? Am I audible? Good enough? Am I audible to everyone? Perfect. Okay, so let's talk of this. So in the first scenario, as I said, that it is the trainer who is driving the car. This is what we know as CMV, or controlled mandatory ventilation. What is controlled mandatory ventilation? I'm repeating it again. It means that in this method, there will be a fixed set of breaths that will be triggered and set by the ventilator. No other supportive breaths are going to be allowed. I repeat, no other supportive breaths are going to be allowed. So the ventilator will be the one who is deciding the rate and the tidal volume of respiration. Apne se you cannot do anything. When is it best? It is the best when the patient is sedated and paralyzed. Yani ki in our training school, this guy is a novice. He has never known how to ride a car. So the trainer needs to ride for the first few days and show him ki dekho, this is how you ride a car. The second image is where both the trainer and the trainee or the student is going to ride the car. This is what I call as a typical ACMV. What is an ACMV? In ACMV, the other name of ACMV is assist control ventilation mode. Okay? In ACMV, okay, the second image is not actually of ACMV. I'm just telling you what ACMV is basically. So basically in ACMV, a minimum respiratory rate will be set on the ventilator, and every breath, be it the patient's breath or the machine triggered breath, will receive the full ventilator support, which means that the ACMV will function like a situation where, suppose I have decided that every 5 breaths will be in every 5 seconds, the ventilator is going to deliver a breath. If the ventilator is entirely going to follow it without allowing patient's breath, it is called CMV. But mano, in certain situations, when the patient is not comatose, the patient is not sedated, the patient also has the will and the effort to and the desire to produce a breath, the ventilator will be saying, okay, I will generate 500 ml tidal volume even when you are breathing. I am repeating. I have set a ventilator setting where I've said every 5 seconds, you will have to generate one breath which will have a tidal volume of 500 ml. So if I'm generating one breath in every 5 seconds, what is the respiratory rate? Everyone, if I'm generating one breath in every 5 seconds, what is the respiratory rate? One breath in every 5 seconds. What is the respiratory rate? In 60 seconds, how many breaths I'm raising? 12, which means the respiratory rate is 12. Yani ki in every breath, I have told the ventilator to give me 500 ml of tidal volume. What is the control that I have set? Is it volume control or pressure control? Based on whatever I've explained you till now, I have told the ventilator every 5 seconds you will give me one breath which is going to deliver 500 ml. Is it a volume control or pressure control? What have I fixed? Volume or pressure? Yes, volume. 500 ml is the volume that I have fixed. So this is called a volume controlled CMV or a controlled mandatory ventilation. Now, Suppose the patient is not comatose, the patient is not sedated, the patient wants to take a spontaneous breath. Now, how was the ventilator set? The ventilator was set in a way that every 5 seconds it will take one breath and it will be delivering 500 ml. Now, suddenly in the third second, mano, first second ho gaya hai, the ventilator has given you a breath. Technically, it is supposed to give you another breath after 5 seconds. But suddenly in the third second, the patient realizes that I will have to give a spontaneous breath on my own. The ventilator will be like, oh, okay, you're confident enough to breathe. Very good. I will give you 500 ml again for your breath, which means now in the first second, ventilator gave a breath, 500 ml. In the third second, patient took a breath that was also supported by the ventilator at 500 ml. And in the sixth second, ventilator will again give a breath because technically it was supposed to give a breath after first second, after 5 seconds means 6 second pe dena tha. It is again giving a breath of 500 ml in the 6th second. Is this clear to everyone? I am repeating again. Ventilator was told to give one breath every 5 seconds. Pehla second mein ventilator give a breath 500 ml. Now, by the third second, now agar patient breathe nahi karta, if the patient wouldn't have breathed, then the ventilator would have delivered the second breath at 6 seconds because 1 plus 5 is 6. So at the 6th second, the ventilator would have delivered the breath. But now the patient is wanting to breathe in the third second. So the ventilator will be very good. Take the breath. I will give you 500 ml. Very good. And again in the 6th second, which was the normal time for the ventilator to give the breath, it will again give a breath of 500 ml tidal volume. Is this clear? This is what we call as ACMV or assist controlled mandatory ventilation. Assist controlled mandatory ventilation, which means a minimum respiratory rate is set by the ventilator. Every breath, be it patient triggered breath or machine triggered breath, will receive the full ventilator support. Okay? The full tidal volume will be given if it's a volume control method, or a full pressure will be given if it's a pressure control method. Yani ki in ACMV, if I keep a pressure control method, if I tell that every 5 seconds you will be delivering 20 psi, then every 25 seconds 20 psi will be delivered. Plus, when the patient wants to take a spontaneous breath, 20 psi will also be delivered even then. Is that clear? Is that clear? Now, come to the second image in this diagram. In the second image, as I said, the trainer has started to be a little confident about his student. And the student is like also, like requesting, sir, please, sir, mujhe thoda chalane do. Please, sir, please, thoda mujhe chalane do. So the trainer is like, okay. In SIMV, a minimum mandatory RR is set, like say one breath every 5 seconds. The ventilator will only give those mandatory breaths, like at first second it will give a breath, at 6th second the ventilator will give a breath, and each of these breaths will be again volume controlled, as it is either volume controlled or pressure controlled. Suppose I'm giving a volume controlled SIMV, that is a VC SIMV, and I've decided that every 5 seconds the ventilator will give one breath of 500 ml, which means at the first second the ventilator will give a 500 ml breath. At the 6th second it will also give a 500 ml breath. But if the patient decides that in the third second it wants to breathe, it will only give a sustained pressure for that breath and not a volume. So what is the difference between ACMV and SIMV? The difference between ACMV and SIMV is support is there, but full support with that volume is given in ACMV, but only mild pressure support to sustain that breath is given in SIMV. Are you clear? Which means SIMV is a scenario where this trainee or student who was requesting, sir, please, let me drive. The trainer did give the student to drive, but he was entirely in control of the car. He did not leave the student, Achha, you want to ride? Okay, let me leave the entire control of the car to you. So repeating again, what is CMV? The trainer is strictly saying, I don't care whether you want to breathe or not. I will be the one running the machine. Every 5 seconds, I will give a breath of 500 ml if it's a volume control. Okay. What is ACMV? Okay. At 1 second, I will give 500 ml. I am supposed to give it again in the 6th second. But suppose you have taken a spontaneous breath at 3rd second, I will again give you 500 ml and support you. And I will again give you a 500 ml at 6th second. Okay. What is SIMV? At 1st second, I've given a breath of 500 ml. Okay. At 6 seconds, I am already scheduled to give a breath of 500 ml. But if you breathe in the 3rd second, I will not give you a volume of 500. I will only give you a sustained pressure. That is the only difference between CMV, SIMV, and ACMV. Is this clear? Is this clear to everyone? Perfect. Now, okay, ACMV. Okay, Dr. Sabia, you are not, you do not understand ACMV. Okay, can we switch to the next slide? I think that will make it clear for Dr. Sabia. No, not this. Agla wala. Na, agla. Yeah, perfect. So this is a very funny slide that I felt like putting in. So we have all had different sorts of parents, with all due respect to them. Some of them, I mean, we all have spent our life in the hostel, right? Again, I would want to put a Hindi example, but then how can I translate this joke into English? I don't know. I'm still trying. So when you are in hostel, you have some parents. Some of our parents, was like, okay, I will give you 5,000 rupees. I don't care. इसके बाद आपको गर्लफ्रेंड को घुमाने ले जाना है या पार्टी करनी है या क्या करना है, I don't care. You have to, take care of the expenses of the entire month with this rupees 5,000 only. I will not be giving you 1 rupee extra. ठीक है? Kind of dusht papa. Sorry, with no offenses to these papas. Because ऐसे बच्चे क्या होते हैं, बड़े डिसिप्लिन रहते हैं लाइफ में, बट बड़े दुखी भी रहते हैं यार. गर्लफ्रेंड को घुमाने ले जाना है, गर्लफ्रेंड को डिनर पे ले जाना है, ट्रीट पे ले जाना है. कैसे करेंगे? 5,000 रुपए में महीना खर्चा चलाना है. Which means if they even want to take their girlfriend out on a date, they will not be able to get a single penny out of the dad's pocket. So that is the dusht papa. That is CMV. Papa is like 5,000 दिया हूं, या in this case 6,000 दिया हूं. हर 5 सेकंड पे I will give you one breath. Your breaths are not allowed. Your opinions are not allowed. 6,000 rupees is what you get in the month. You have to spend your entire expenses with 6,000. Not 1 penny more, not 1 penny less. समझ गए everyone? CMV clear? Dusht papa का example. Everyone is clear with this? Thumbs up for this. Thumbs up for this. If you have understood Dusht papa, CMV. Okay. तो ऐसे बच्चे disciplined बड़े होते. They know how to spend their income or पैसा in a very proper way, but they also stay a little sad in life, of course. But let us understand the बहुत cute papa. Who is the बहुत cute papa? Chalo, he has also given you 6,000 rupees for spending the month, but suddenly you call him up and say, papa आज girlfriend को घुमाने ले जाना है. Like, अरे बेटा, just like the Jamil मामू, अरे बच्चा है तो मेरा, चल फैंटा पिलाता हूँ, चलो गर्लफ्रेंड को घुमाने ले जाना है, I'll give you 1,000 more. That is exactly what Jamil Mama is. He is the assist control mode, which means, can you now see the red lines are exactly where every breath was given by the ventilator one breath was given every 5 seconds. That is the red line. That red line is constant even in CMV and ACMV. But the yellow line is when the patient starts taking breath. Can you see that the ventilator is continuing to produce 1 breath every 5 seconds and is delivering a tidal volume of 500 ml. But in beach mein, in the middle, when the patient is also wanting to breathe, that is depicted by the yellow line, the ventilator is again giving a 500 ml for even the patient's breath. तो ऐसे बच्चे खुश तो बहुत रहते हैं, पर हम लोग क्या बोलते हैं कि अरे पापा ने इसे बिगाड़ के रखा है. तो बिगाड़ने वाला पापा या बहुत क्यूट पापा, whatever you call, is the assist control mode ventilation. डॉक्टर साबिया, अब क्लियर है? अब क्लियर है? दोनों वेंटिलेशन क्लियर है अभी? परफेक्ट. ना अब दोनों में ही कुछ पॉजिटिव्स है, दोनों में ही कुछ नेगेटिव्स है. भाई दुनिया तो दोनों चीजों से चलती है. So in one hand, the CMV का दुष्ट पापा might be a very strict disciplinarian, but the good part is he's very disciplined. But what is the bad part? These kids, when they grow up later in life, they start getting very depressed and they start fighting or, rebelling their parents. That is exactly what happens in case of a patient on CMV for a prolonged time. As long as the patient was comatose, as long as the patient was sedated, CMV was absolutely doing the work great. But once this bacha has started to grow up, he has started to see his friends. And he's now telling his dad that, Dad, ye kya hai? Main apni girlfriend ko ghumane le jana chahta hu. You are not giving me 1 penny extra. What is this? He starts becoming rebellious. That is when the patient starts fighting with the ventilator. And that is exactly what we call as a patient ventilator asynchrony or dyssynchrony. यानी कि the patient fights with the ventilator to take his own spontaneous breath, but the ventilator is not allowing that. That leads to tachypnea and agitation in the patient. Am I clear? Thank you so much, Dr. O.P. Gautam. Thank you so much. Is this clear to everyone? So one good part of Dusht Papa was he's a disciplinarian, but the bad part is now the patient is no more comatose, and if you keep the patient who is not comatose on a CMV, he will start to fight with the ventilator, and that will lead to a patient ventilator asynchrony. हो गया? Now let's talk of the positives and negatives of ACMV वाले पापा. That is बहुत cute पापा या बहुत बिगाड़ने वाला पापा. The good part is patient ventilator asynchrony will never happen. Patient खुश, ventilator खुश. पेशेंट बोल रहा है पापा थोड़ा पैसों की पंगी. अरे पंगी क्या है बेटा, चल तुझे 150 और भेजता हूं, अरे 500 और भेजता हूं. बट इससे क्या होता है, बच्चे बाद में बिगड़ जाते हैं. यानी कि दे बिकम एक्स्ट्रावेगेंट किड्स, दे डू नॉट नो व्हाट इज द वैल्यू ऑफ मनी. वैसे ही इफ यू नाउ रियलाइज दैट सपोज आवर टारगेट tidal volume, as I said, our target tidal volume is 4 to 6 ml per kg of body weight. Yani ki if I am having say a 70 kilo patient with me, what is the ideal body weight? I mean, what is the maximum tidal volume that I can give? 70 into 6, that is 4200 ml. Okay. But in this case, whenever I am, giving or let us take the example of someone who will have an ideal volume of 6000, because I think that will be easier. So for getting a 6000 ml of tidal volume, I think the approximate amount of that we need to give is how much? 4 to 6 ml of body weight के हिसाब से अगर हम 6000 जाए, what is the amount of tidal volume that what is the weight of this patient? What is the weight of this patient who is supposed to receive 6000 ml of tidal volume? Anyone? Mathematics? Dr. Twinkle? What is going to be the weight of this patient who is supposed to receive maximum of 6000 tidal volume? 4 to 6 ml per kg of body weight के हिसाब से find out. So yes, let's say it's a 100 kg patient. ठीक है? Let's say it's a 100 kg. हालांकि मैं 100 वाला example नहीं लेना चाह रहा था. Okay, let's stick to the 70 kg patient only. Let's stick to the 70 kg patient only for a while. So 70 kg patient को approximately I want to give 4 to 6 ml per kg body weight of tidal volume, which is like, chalo, it is around 4200, which means that if you actually see that in assist control method, what is happening is 500 ml is being given in every breath by the ventilator, but even when the patient wants to breathe, 500 is being also given to the patient when the patient wants to breathe. In this case, the tidal volume that is now being delivered is 7500 ml. Can you now see? Can you understand why 7500? Can you calculate it? Everyone is clear with why it is 7500? There were 12 breaths, each breath having 500 ml delivered. That is 500 into 12, 6000 ml. Now, the patient has additionally also taken 2 more breaths of 500 each, which means almost 7000 or 7500 ml of tidal volume has been delivered to the patient due to the patient spontaneously breathing. And as I said, this cute papa is actually spoiling the baby, because an ventilated lung is an injured lung. Whenever the target for your tidal volume was 6000, but now you are achieving a volume of 7000 or 7500, it can lead to volute trauma. It can lead to volute trauma. Is this clear? Which means दोनों पापा ही best नहीं है. The CMV वाला papa is a strict papa. The child becomes rebellious to such a papa and starts developing ventilator patient asynchrony, agitation. That agitation will increase respiratory rate, can worsen hypoxia. He might try to pull the tube off. He might crash. He might have an arrhythmia. Also, the बहुत cute papa is also a बिगाड़ने वाला papa because he is providing more amount of tidal volume, which can lead to volute trauma in this patient. So, what we need in life is a balanced papa. What is a balanced papa? That balanced papa is exactly what is SIMV. Take me back to the previous slide of SIMV, please. Yes, Winkle, what I'm saying is 6000 की tidal volume is what I needed. Now, due to ACMV, the patient is also taking few additional breaths, which are also being given 500 ml. Now, this tidal volume that the patient has achieved is 7500, which can lead to volute trauma. Also, this extra breath that this patient is taking will lead to a phenomenon called hyperventilation, and hyperventilation will later lead to respiratory alkalosis. Is this clear, Twinkle? Twinkle, is that clear? Hyperventilation can lead to respiratory alkalosis. Perfect. So, what is the best papa to us? Neither CMV, neither ACMV. The best papa is balanced papa, that is SIMV, where the papa is like, okay, I am giving you 6000, try spending the month. अगर कुछ प्रॉब्लम आ जाता है, I will try giving you a support, but I cannot promise that I will be giving you exactly the amount of money that you require. That is exactly what a balanced papa is. ऐसे बच्चे ना बिगाड़ते हैं, ना दुखी रहते हैं, बीच में रहते हैं, they understand the value of money, they also have fun in life. ठीक है? Is this clear to everyone? Clear? Next slide, Dr. Njim. So we have already talked of volume control. We have already talked of pressure control. Flow is something which you should be knowing. Flow is the amount of gas that is going per minute to the ventilator. And upon experiments, we have found that 60 liter per minute is the baseline flow that we start with. We can always reach up to 100, but 60 liter per minute is usually what we start with. And the amount of flow that we are giving into the inspiratory time. So basically what happens is there are two valves on the ventilator. One is an inspiratory valve, the other is an expiratory valve. The inspiratory valve and the expiratory valves both are time dependent. यानी कि they will remain open for a very limited amount of time. Okay? So the amount of flow into the inspiratory time is going to decide the tidal volume, which means if a flow is 60 liter per minute, it clearly means it is 60,000 ml per minute, which means it is 1000 ml per second. Everyone is clear with this mathematics? 60 liter per minute is 60,000 ml per minute. That is equal to 1000 ml per second, because 1 minute is 1 by 60 seconds. So if I at all need to give tidal volume of 500 ml and my flow rate is 1000 ml per second, I need to keep the valve open for 0.5 seconds. Is that clear? Everyone's getting me? If I really need to give a tidal volume of 500 ml, then I need to keep this valve open for 0.5 seconds. Is that clear to everyone? Perfect. Great. Next slide. Next slide. Okay. No. Pichla. Graphics. Yep. Good. Now this is something which is going to be super easy. It looks scary. Okay. First of all, these diagrams are directly taken from a ventilator. So I have tried to put in the most original images that I can. So the first one on the left is a graph on spontaneous breathing. So as I said, normal breathing versus ventilator breathing, the only difference is normal breathing is negative pressure ventilation, whereas ventilator is positive pressure ventilation. Everyone is agreeing to that? Normal breathing is negative pressure ventilation, where we create a negative intrathoracic pressure for suctioning the outside air inside. And the ventilator is going to give you a positive pressure ventilation. Correct? Very good. Now, let us see this graph. So the graph on spontaneous breathing, we have three graphs which are plotted over time. So the x-axis is time and the y-axis will either show me volume, it will either show me flow, or it will show me the alveolar pressures. How do you understand whether a graph is a venti graph or a normal breathing graph? Kuch bhi nahi. Just check the alveolar pressure graph. If the alveolar pressure graph ka decreasing is leading to an increase in tidal volume, it clearly means that the tidal volume that is being achieved through a negative intrathoracic pressure. Am I clear? Can you see this in this curve? The left curve, the left hand side graph, yes, that P alveolar, whenever it is at the dip at the negative point, that is when we are achieving the maximum tidal volume. Nahi, not there, Dr. Imjim, that is the flow curve. That is the tidal volume curve. Come to the third curve, niche. Yes, yes. So whenever there's a dip in the alveolar pressure, and the maximum dip in alveolar pressure is corresponding to the maximum rise in tidal volume. Can you all see that? The laser is being beautifully pointed. And conversely, when the tidal volume is decreasing, yes, that is leading to a positive pressure or a upstroke on the alveolar pressure curves, which means expiration is a positive airway pressure generated inside the alveoli, and inspiration is a negative pressure generated inside the alveoli. Is everyone clear with this? That this is a graph of spontaneous breathing and not ventilator? Sub clear hai? This is the spontaneous breathing curve, not a venti curve. Okay, very good. Why is the response in the group so suddenly muted and quiet? Why is the response so muted and quiet? Everyone, I want all of you to be active. Yeah, very good. Okay. Okay, one more. Yeah, exactly. So if you want me to speak once more, I will be again saying it. Okay, Dr. Gladys, turn on your mic for a while. Just turn on your microphone for a while. Vijay sir, can we turn on Dr. Gladys George's microphone for a while? Dr. Gladys, are you available on the microphone?
Yes, sir.
Yeah. Okay. Hi. Okay. So okay, Dr. Gladys, is that your good name?
Yes, sir. Gladys.
Okay, Dr. Gladys. Okay. So, Dr. Gladys, you agree with me that whenever you are taking a normal inspiration, currently, you are not on the ventilator, you are taking a spontaneous breath. Please take a deep inspiration for me. Okay. Once you have taken a deep inspiration, do you agree that this is due to the negative intrathoracic pressure?
Yes, sir.
Very good. Can you clearly see that the alveolar curve that is in the third part? Dr. Imjim, can you please can you please point the laser better for her? Yes. Can you please see that this curve, whenever it is starting from a negative phase waveform, whenever it is in the most negative point, that is corresponding to the highest tidal volume that is inspired.
Yes, sir.
Yani when the maximum intrathoracic pressure is negative, that will also be the point of maximally inspired volume.
Yes, sir.
Very good. That exactly explains why it is a curve of spontaneous breath. Clear?
Okay, sir. Thank you.
Okay. Okay. Gladys, very good. Lovely having you. Okay. Now, let us come to the venti graph. Okay. So, for the topmost curve, Dr. Imjim, slide pointer. Yes. Now, what you can clearly see. First of all, how do we know it's a venti curve? We know it is a venti curve because tidal volume is still increasing, but for that, the red curve downwards, that is the pressure curve, is increasing, which means a positive pressure is being given in order to maintain an increase in tidal volume. This is how you differentiate a venti graph from a normal spontaneous breathing graph. Clear hai? Itna clear hai, everyone? Okay. Thumbs up. I want thumbs up. If everyone's clear, thumbs up. So what I'm saying is the red curve is the pressure curve, and you will find that it has a positive waveform or a upstroke. So Dr. Sagar, I'm again saying it. How would you understand that this is a venti curve? The venti graph is understood by the fact that the tidal volume is still increasing, but the increase in tidal volume is due to an upstroke or a positive pressure that is being given. See the red curve, it is in the positive or the upstroke deflection. There is no downstroke deflection below the baseline. There is no part of the red curve below the baseline. Can you see that? Dr. Sagar, is that clear with you? Dr. Sagar, is that clear with you? Perfect. Now, this means it's a venti curve. Now, is it a pressure control curve or is it a volume control curve? How do I understand that? So the second curve, that is the green curve, is actually the flow curve, right? The red curve is the pressure curve. Can you see one constant thing? That the green curve, Dr. Imjim, please point it with the laser, not there. And I'm still talking of the first curve. Yeah. Yes. So can you see one thing, that the flow levels are constant? The flow is constant. Yes, that horizontal segment that you are being shown is the flow constant. The horizontal segment is the flow constant. Whenever the tidal volume of 500 ml is being reached, it is being reached at a constant flow. And the flow, as I said, is 60 liter per minute, which means I am controlling the volume of air that I'm delivering through the ventilator. Conversely, as I said, the volume is being kept constant, but the pressure is increasing due to the tidal volume being generated. Hence, this is a volume control curve. How comfortable is everyone with this explanation? Anyone who has not understood what I said? For the curve on the top, I repeat, tidal volume is being generated, and the green curve, that is the flow curve, is constant whenever there is a yes. So it is a constant curve. That horizontal segment that you are seeing is a constant horizontal segment, which means that volume has been kept constant, whereas pressure is increasing. Volume has been kept constant and a certain pressure is increasing. Is that clear? Is that clear to everyone? Perfect, perfect, perfect. Now, let's come to the curve below. So, in the first two waveforms, you will be finding that this is the volume control graph, because you can clearly see that in the first waveform, yeah, exactly. Just point it here. I'm not going to talk of the above curve anymore. I'm talking of this curve. The first waveform is a volume control waveform where you are finding that the yellow line, which is showing tidal volume, is going up. Yes. And that is being associated with a constant flow that is being given in the green curve below. Yes, yes, yes. But we are now going to switch this mode from VC to PC, that is from volume control to pressure control. How do I know that pressure is now constant? Just see how the red line curve changes. The red line now becomes constant. Yes, this constant red line is showing that the pressure is being controlled in a constant way, and the volume is now the independent variable. So this curve brilliantly shows the switch between the volume control to pressure control. So in volume control, the flow curve will be horizontal, and the flow is straight, but the pressure is going to be steep and increasing. Whereas for volume control, for pressure control, the pressure curve is going to be straight and the volume is going to be independent and variable. Is this clear to everyone? Is this clear to everyone? Everyone's clear with this? Perfect. Shall I move ahead? Okay, good job. Okay, next slide. We have done this. Let's take the next slide now. Okay, now let's talk about concept of I is to E time. Now, for the first curve, for the first graph, that is on the left hand side top, this is a very simple mechanics of breathing. Can you zoom into this slide a little more, Dr. Rimjim, for me? Yes, fantastic. So we can see that first of all, there is a baseline, and from the baseline, we are starting to inspire, and the horizontal segment is showing the maximum point of inspiration. Following inspiration, we are now going to gradually begin into the phase of expiration. Now, generally in ventigraphs, this is more of a theoretical graph, but in ventilators and in normal physiology also, there is no time duration between inspiration and expiration. There is no much of a duration between inspiration and expiration when it comes to seconds. But definitely, when we talk of milliseconds or micro moments, there is definitely a transition that is occurring between inspiration and expiration. From this graph, one thing is very clear, that the horizontal segments which are closer to the baseline are actually showing the phases of expiration, whereas so this is the phase of expiration, whereas the top portions are the phases of inspiration. Very good, very good. Okay, now please take me to the right hand side. Take me to the right hand side. Yes, zoom this. So suppose I have set a respiratory rate of 12 breaths per minute. In this curve, can you clearly see that the green lines are the inspiratory lines and the pink lines are the expiratory lines? Okay. Now, what do I mean by, suppose I've set a ventilator for 12 breaths per minute, which means every cycle time is 5 seconds. Yani ki in 5 seconds, the ventilator is going to deliver me one breath. Let's say that we keep the inspiratory time as 1 second. What is inspiratory time? It's T insp. Let's keep T insp as 1 second. What is the remaining time for the cycle? It is 5 minus 1, that is 4. So the remaining 4 seconds is the time for expiration. So what is the IE ratio? It is 1:4. Now you can clearly see how many green lines are there. Count it for me, Dr. Mjim. 1, 2, 3, 1, 2, 3, 4, 5, 6, 7, 8, 9. More. Do we have more? Can you zoom out? Can you zoom out the slide? Dr. Injim, can you zoom out the slide for me, please? Yes. Okay. So yes. So still there are supposed to be more breaths. There's supposed to be 12. For some technical reason, it's just come out to be 10. But as I said, what I want to say is, suppose I've kept the setting as 12 breaths per minute, which means that every 5 seconds, the ventilator will be giving me 1 breath. Suppose I set the inspiratory time as 1 second, the expiratory time becomes 4 seconds. And you can even see in the diagram that the time for the green lines is smaller than the time for the pink lines. As you can clearly see that the pink lines are longer than the green lines, which means that the expiratory time is higher, 1:4. Can you please tell me, with your common sense, in which sort of diseases do we want the expiratory time to be higher? Which diseases, which pathologies in the lung have a problem with expiration? Which diseases or which lung pathologies are having a problem in expiration? सांस लेना दिक्कत नहीं है, सांस छोड़ना दिक्कत है. Exactly, Dr. Nikita Sharma, Dr. Arthi Priya, exactly. So COPD, be it emphysema, be it bronchitis, all of these places we are having a situation where there is significant air trapping, and due to the air trapping, we want more amount of time to be given for expiration. Is that clear to everyone? Is that clear to everyone? Correct. Now, suppose we are decreasing the respiratory rate to 10. What will be the cycle time? 6, because 60 by 10 is 6. Which means now, instead of providing a breath in every 5 seconds, the ventilator will provide the breath every 6 seconds. And if I keep the inspiratory time as constant 1, then the IE ratio becomes 1:5. Is that clear to everyone? Is that clear to everyone? Very good. Now, please take me to the bottommost picture of this slide. Yes. So this is another thing, very simply explained. Let's say that the tidal volume is 500. Okay, number one, tidal volume is not what we fix at 500. I've taken this example of 500 for the sake of good calculations. Again, I'm saying, whenever I talk of tidal volume on the ventilator, it should be 4 to 6 ml per kg of ideal body weight. Okay, now what do I mean by ideal body weight? Ye concept I forgot to tell you. I mean, suppose a 60 kg man is coming to you. What is the ideal tidal volume? 4 to 6 ml per kg ke hisab se it should be 16 to 4 240. 16 to 6 is 360. So my tidal volume should either be between 240 ml to 360 ml, correct? But what if a 200 kg man comes to you? Do you think you will be giving 800 to 1200 ml tidal volume to this patient? It is not going to happen, because this patient's lung will burst out. So if it's a 200 kg man or a 300 kg man, you are not going to multiply 300 with 4 and 300 with 6. This is the ideal scenario where we talk of an ideal body weight. What is an ideal body weight? It means we are of this presumption that despite the person's weight being 200 kg, the lungs are still going to tolerate a maximum tidal volume of 4 to 6 ml per kg based on what an ideal 70 kg man should. So that is when we fix the ideal body weight to be 70 kg. Am I clear to everyone? Here, for sake of calculations, I am just putting the value as 500. Don't think that hamesha tidal volume 500 hi rakhne. Okay? If it's a 50 kg patient, you will not keep a tidal volume of 500. Okay? You will be keeping a volume of say around 250 or 300. Okay? Now, suppose the tidal volume is 500, flow is 60 liter per minute, and respiratory rate is 20. What does respiratory rate of 20 per minute mean? 20 breaths are there in 60 seconds, which means that the total cycle time is 3 seconds. Total flow is 60 liter per minute, which means 60 liters of air is moving in 60 seconds, which means 1 liter is moving in per second, or 1000 ml is moving in per second. If my tidal volume is decided at 500 ml, what does it mean? That the inspiratory time has to be 0.5 seconds. We already saw that a while back. Clear? Clear? Now, if my total cycle time is 3 seconds, and I have to keep an inspiratory time of, an inspiratory flow valve opening of 0.5 seconds, what is exactly my T-ins? My T-ins becomes total cycle time minus this 0.5 seconds, that is 2.5 seconds. So, I'm again repeating it. My total cycle time is 3 seconds, but to give a volume of 500 ml, I have to keep the valve open for 0.5 seconds. Which means, what is the time that the patient is inspiring for? 3 minus 0.5, that is 2.5 seconds. What is the IE ratio? In T-insp is 2.5, T-insp is sorry, this will be T expiratory. So sorry for that. This will be T expiratory. This is going to be T expiratory. That is total cycle time minus T inspiratory. That is 3 minus 0.5. That is 2.5. What is inspiration to expiration ratio? It is 0.5 is to 2.5. That is 1:5. Is this clear with everyone? I'm repeating again. Suppose my tidal volume is 500, flow is 60 liter per minute, and 20 is the respiratory rate, which means the total cycle time is 3 seconds. If I am able to deliver 1 liter per second or 1000 ml per second, but my required tidal volume is 500, okay, I'm explaining this to you again. Dr. Twinkle, I am clearly saying this. My tidal volume that I'm supposed to give is 500 ml. But flow is 1000 ml per second, which means my T inspiration should be 0.5 seconds. Is this clear to you, Dr. Twinkle? Is this clear to you? Okay, then what is the time for expiration? Total cycle time is 3. Total inspiration time is 0.5. What is that expiration time? 3 minus 0.5, that is 2.5. Clear? Dr. Twinkle, clear? Expiration time is 2.5. Inspiration time is 0.5. Clear? What is the IE ratio? 0.5 is to 2.5. That is 1:5. Clear? Is that clear now? Sahi hai? Clear with everyone else? Clear with everyone else? Perfect. Let's move to the next slide. So ये सारे concepts हम लोग पढ़ रहे थे, हमारी जिंदगी अच्छी चल रही थी, our life was going beautiful. That is only, I mean, our car that we started, as I said, I'm drawing the analogy of driving a car with the ventilator mode. Our car was going well when suddenly a sound comes. What is the sound? Dr. Rimjim, play the sound. No, no. Yes, that is when suddenly a sound plays, and the sound is of an alarm. The alarm is, however, not being able to heard because you have not turned your pointer off, Dr. Rimjim. You need to turn your pointer off. Yes. So we were all acquainted with a good driving of the car until suddenly we come across an alarm. And post alarm, we are like, oh my God, Amma was ventilated well. The urosepsis patient was ventilated well. From where is this alarm coming? How many of you have encountered this situation that you have stabilized all the 4 patients that have come to the ICU, you have ventilated them, and suddenly you are, trying to take a little nap or doze off a little when the alarm has rung? How many of you have encountered such a situation? So the alarm has rung and you are suddenly trying to find out which is the patient who has, started to desaturate, or which is the patient who is not doing well. That is exactly when we will move into the second segment, and I will tell Dr. Rimjim to play this video. That so yes, this is exactly when the alarm sets off, and we are exactly at this point where we will take a commercial break of 2 minutes, where I will be answering all your queries that you have to ask till now, because the second segment is going to be really short, and we'll be trying to see why the alarm set off and what were the reasons that this alarm is what we need to tackle. Okay, can I have the questions? Can I have questions? Am I audible? Am I audible currently? Yes. Okay, perfect. Is there any question that I can take on before I enter into how to treat alarms and how to understand why the alarm set off? Any questions that I'll take? I'm only receiving yeses. I do not know whose background is on, but I would request you to switch your mics off. Yes, it is an extensive session. When I have been given ventilator, I cannot finish it in 1 hour. It is impossible because अगर 1 घंटे में मैं वेंटिलेटर पढ़ाने जाऊंगा तो कुछ भी नहीं आएगा दिमाग में. It is, as I said, it is an extensive topic. It needs quite a bit of detailing. And whatever I'm detailing currently is only 10% of the ventilator. It is not even the remaining 90%. My work is to infuse an interest in you so much that you will be able to read more about the ventilator. CPAP versus BiPAP आज नहीं हो पाएगा डॉक्टर आरती प्रिया. I'm so sorry. But धुरंधर 2 जैसे आ गया वैसे ventilator 2.0, but not the revenge. The detailing of modes, definitely we will be able to do CPAP BiPAP there. Any more questions till here? Any more questions till here? Even in obese or normal? Yes. Even in obese or normal, we do it as circuit loss inventory. Nah, not today. Not today, Dr. Twinkle. I'm so sorry. Dr. Twinkle, do you realize that only a very few people have worked in the ICU and are aware of the word ventilator? My first work is to make sure that you all know what a ventilator graph looks like. I am taking so much time to explain you a ventilator graph. Some of them, of course, and I'm not blaming anyone. It's so good to have different sections of the audience. But then, as I said, I cannot make it more complex by talking of circuit disconnections. I will talk a bit about that, but not much. No, there is nothing to be sorry, Twinkle. Rather, I will be telling all of you to write to Mediversal so that they give me another webinar on ventilators. ठीक है, we will be taking up modes and other details of ventilators on that day. ठीक है, okay, चलो, I hope there is nothing. Let's begin. Break खत्म सबका, आ जाओ वापस. Dr. Rimjim, let's move to the next slide. चलो, so ladies and gentlemen, alarm बज गया था. That's where we left. Let's do this.
Get ready. Mama say they call me a bad man. That's a fucking good thing. Mama said swing back.
Okay, let's move to the next slide. Are you all ready? Geared up? Pani wani pee lo, everyone. Sip your cup of coffees. Okay, next slide. Yeah. Okay. Chalo. Dr. Twinkle, can I have you on microphone, please? Dr. Twinkle, can I have you on microphone?
Yes, sir. Good evening, sir.
Hi, Dr. Twinkle. Good evening. Okay, where are you working in currently, Dr. Twinkle? Which hospital are you working in?
Bombay Hospital.
Oh, Bombay Hospital. Okay. So you, yeah, I think I've had a talk with you before. Okay, Dr. Twinkle. So we were talking of 4 case scenarios, right? The first case scenario was an alcoholic female who was found unconscious, sleeping pills. Second patient was a patient who was with pneumonia being treated in the ward, suddenly desaturated. Third case was that Amma who was 68-year-old asthmatic, known COPD patient. ठीक है? And fourth patient was urosepsis. अभी एक alarm बजता है, and in the alarm you come and find that okay, the patient who was having pneumonia is the one जिसका alarm बज रहा है. What might be the cause of the alarm in this patient? निमोनिया के पेशेंट में आपने सब सेट वेट कर दिया था, सब सही चल रहा था. मानो आपने वॉल्यूम कंट्रोल मेथड पे, अभी ये जो ग्राफ आपको दिख रहा है उसमें नॉर्मल वॉल्यूम कंट्रोल में आपने सेट किया था, एंड द पेशेंट वाज बीइंग वेल मेंटेन्ड. सडनली what happens is, no, Dr. Nimjim, I do not want you to take me back to that case. Please don't do it. I want you to be where you were. Yes. So Dr. Twinkle, what might be the cause of an alarm? Aap alarm bajta hai and then you come. No, I want the previous to previous slide. You are in the wrong slide, Dr. Rimcham. Yes, good. So you come and you find that there is a peak or a peak pressure alarm or a PIP alarm that is being raised. What is PIP? Dr. Twinkle, if you can share it with our audience. Do you know the concept of PIP?
Hello.
Yes, Dr. Twinkle, you're audible.
Hello, sir. Your voice is unclear, sir. Sorry.
Yeah, what I'm trying to say is you finally find that the patient of pneumonia has worsened and the ventilator is showing you an alarm for PIP. Pressure
Okay.
alarm dikha raha hai. What does
Yeah.
this PIP alarm or a pressure alarm mean?
So pressure alarm is too high, that is creating a worsen the injury of the lungs, sir.
Absolutely. So what do we need to do in such a situation?
We have to adjust the more PEEP and the tidal volume according
Perfect.
to the ABG.
Perfect. Very good. Very good. Okay. So Dr. Twinkle has given a perfectly correct answer. For I know there are many who will be not understanding what she said, and for that I am there. Your Jamil Mamu is here. Let's begin this. Okay. So what happens is, let's first, Dr. Twinkle, you can mute yourself now. So let us first look at the first graph of a normal patient. Okay, this patient was electively operated and electively intubated. Post-op, this patient has been put on a ventilator. Now, can you all quickly tell me in the chart, in the chat box, what is this first graph showing me? Is it a volume control method or is it a pressure control method? Everyone, I want answers from everyone. पहला जो ग्राफ आपको दिख रहा है, is it a volume control curve or is it a pressure control curve? Okay, Dr. Sagar VC, very good, perfect. More. Aarti Priya, very good. Dr. Durga Parida, very good. That is very good, lovely. More answers. Dr. Twinkle, very good. Okay, so you all agree it is a volume control. क्यों कैसे पता है volume is? आप ध्यान से देखो कि the flow is constant, flow is maintained at 60, and the pressure is what is changing. And we can see that at the topmost peak of that increasing slope of pressure, the highest tidal volume is given. What is the tidal volume that is generated? It is an earnest request for me to, for everyone to mute themselves unless they are, requested to come. Okay. So, as I was saying, I still do not know whose microphone is on. Vijay sir, are you there? Vijay sir, are you there? Just give me a moment.
Dr. Pratibha, I earnestly request you to mute yourself.
Okay, yeah. Okay. It's my earnest request. I do not like being interrupted in the middle of my sessions, and not just me. I think it's a disrespect to anyone who's doing this. So please do not make such noises further. Anyway, okay. So I am currently not turning my video on because I am suffering through an episode of lower back pain. So I'm extremely sad about that. But yeah, I'm trying to put in my bit even on a day when I'm not at my best of health. I expect everyone to maintain the decorum of the session. Okay. Now, coming back. So in the first graph of normal post-op ventilation, can you clearly see that a tidal volume of around 475 ml has been generated with an alveolar pressure of around 20. Can you see that? 20.92 wala pressure. Let us say 21. 21 ka pressure, 21 ka pressure is almost generating a tidal volume of 475. Okay. What now starts happening? When this patient, say post-op patient, for example, has a very high risk of going into ARDS. When this patient starts developing ARDS, what starts happening is, to achieve the same tidal volume, now the alveolar pressures are raised because we know ARDS is an example of a stiff lung, which means the compliance of the lung is increased. Which means now, can you see that now to generate a volume of 459.47, which is close to 460 ml, alveolar pressure of 31.37 centimeters of water is being required. Can you understand this? That a higher pressure is now required to maintain a tidal volume that we were wanting to keep. Suppose we wanted to keep a tidal volume between 400 to 500. Earlier, the pressure that was being required is 20. Now, for the same amount of volume, almost 31 units of pressure is being required, which means that the compliance of the system has been increased, which means that, sorry, the compliance of the system has decreased, which means higher pressures are now being required to inflate the system. Is this clear to everyone? Is this clear to everyone? Earlier, we were generating 475 ml with a 21 atm pressure, 21 centimeter pressure. Now we are generating only 459, that too with 31 centimeters of water, which means that the patient's compliance has decreased and the patient is worsening. Further, let's move to the next slide. Let's move to the next slide. So can you now understand that suppose at a pressure of 27, this patient is getting only 369 or 370 ml. Suppose my required tidal volume to be given was between 400 to 500. Earlier, 21 centimeter of water or 25 centimeter of water was enough to produce that volume. Now, because of a decreased compliance, I am not able to generate the pressure to maintain that tidal volume. In fact, even with a higher pressure than 20, which is around 27, I'm only able to generate 369 ml, which is lower than my requisite tidal volume. This is exactly why my alarm is going on. Now, the patient is further worsening. Now, to maintain a volume, the required tidal volume is still between 400 to 500. Now, to maintain a volume of around 487, look at the amount of alveolar pressure that is required. That is close to 45, which is double the amount of pressure that the alveoli can tolerate. This is exactly what is going to set the alarm on. So, now, the major reason for the alarm that went on, जिसके बाद हमने एक commercial break लिया था. So why did the alarm go on? The alarm went on because this is known as a peak pressure alarm. This is known as a peak pressure alarm. I'm repeating. See the graphs clearly. Can we go to the earlier slide? Suppose this patient required a tidal volume maintenance between 400 to 500 ml, the earlier slide. Dr. Jim? Yeah. So normally this patient required a volume between 400 to 500 ml, and it was being well maintained with a pressure of 20 centimeters of water in the alveoli. Now this patient has started to develop ARDS. The lungs are getting stiffer. The compliance of the system is decreasing. Now, even at a pressure of 31, we are only maintaining 459 or 460 ml. And if we have to see, 21 के pressure में, 21 के pressure में earlier 475 was being maintained. Now, even at a pressure of, the next slide, please. The next slide, even at a pressure of 27, we are only able to generate only 369 ml of volume, which is lower than the requisite tidal volume that we want in this patient. As the ARDS is going to worsen, as the patient is going to worsen, this is going to even become worse because now double the amount of pressure. Earlier pressure was 20 centimeter of water in the alveoli. Now it is 45, which is more than double the amount of pressure required to maintain the same tidal volume. This shows that the alarm has set off for a peak pressure alarm or a peak alarm. Move to the next slide. Now, what is PEEP? As I said, when a patient has to breathe in, normally the patient has to, in a spontaneous breath, the patient has to overcome a lot of resistance of the airways. But whenever it comes to a ventilator, it has already bypassed the upper airway, but it is at the level of the, say, trachea or the carina. Now, whenever we call a venti pressure, we are typically meaning the pressure of the ventilator at its tip, where the oxygen or the air is being delivered. So the total pressure that is generated from the trachea to the carina, at the place of bifurcation to the bronchi, bronchioles and alveoli, this entire system ka pressure is what we call as the P peak. However, a higher P peak does not necessarily mean that the pressure in the alveolus is more. It means that the pressure in the total system is more. या फिर the resistance of the total system is more. What is the system? The system begins from the trachea, goes to the bronchi, to the bronchioles, and the individual units of the alveoli. If I really want to know that if a peak alarm has been set, as the alarm went on in the last case as we were discussing, that when an alarm has been set on, we find that it's a peak alarm, we have to understand that, okay, I understand it's a pressure alarm, but is this alarm telling me that the pressure at the total airway resistance is high, or is the pressure only at the level of the alveoli high? For that, we have to know certain parameter which is called the P plat or the plateau pressure. I'm repeating again. The pressure individually at the level of the alveoli is what you call as the plateau pressure, whereas the pressure which is totally throughout this entire circuit of the trachea, bronchi, bronchiole, and alveoli is what you call as the peak pressure. But a ventilator, however, only is able to measure the peak pressure. It is not able to measure the plateau pressure. So whenever a peak alarm goes on, it shows that the peak pressure is high, which means the pressure of the entire system has been increased. It may not always translate to an increase in the pressure at the alveolar level or the P plat. So how do you understand whether it is an increase in the total system that is causing a high P peak, or is it an increase just in the P plat that is causing a high P peak? For that, we have to refer to this graph. Yes, to this curve that is there on the right of this image. Can you please zoom this curve for me, Dr. Rimjit? Yes. So can you see that this upstroke that you find, please use the laser monitor for me, Dr. Rimjit. The upstroke that you find, yes, which is there till the highest point. Yes, please zoom and use the, yeah. So the upstroke, can you please trace the upstroke for me? Can you please trace the upstroke for me? Trace the upstroke for me, Dr. Imjim. Trace the upstroke from the break point till the peak pressure. Please trace the upstroke for me. Yes, so this is the pressure that is building up in the entire system from the trachea to the lung units. And the highest point of this is what I call as the peak pressure. But as I said, a higher peak pressure is what is detected by the ventilator and the alarm is switched on. But does it have to mean that the plateau pressure is also high? No. How do I measure plateau pressure? The measuring of plateau pressure is done by a method which is called the inspiratory hold. Yani ki previous slide. Just at the point where the alarm is giving me a peak pressure alarm, that is the point where I will be switching off the inspiration button on the ventilator for around 3 to 4 seconds. At least 3 seconds, if I switch off the inspiratory valve or the inspiratory button, what clearly means that now the pressure that I'm finding in the system is the pressure at the level of the alveolus. That is what I will call as the plateau pressure. I repeat, when the ventilator sets off a peak alarm, it is setting an alarm to show that the total resistance of the system is increased. It may be a resistance of just the alveoli, which is a high P plat or a plateau pressure, or it may be a resistance at the level of the trachea to the bronchi to the bronchioles to the alveoli. Now, whether a high P peak means a high P plat or not will have to be determined by doing an inspiratory hold for 3 seconds, by which we can measure the P plat. Can you now see the graph that is there? Please zoom in to me for the graph. You can clearly see that currently even though the P peak alarm was being set off, but the P alveolar pressure, that is PAW, is still very normal, that is 18.11, which means that the alarm that was set off for a high peak pressure was actually a pressure of the total resistance, but it did not affect the alveoli, which means that the alveolar pressure is still normal, which means the problem is not inside the lung unit of the alveoli, which means that there is no problem with the compliance of the alveoli. There is a problem somewhere else. What is that problem? We will search in the next slide. Is this part clear to everyone? There's only one take-home message from this slide. A high P peak is what is going to set off an alarm. A high P peak does not mean a high P plat. A P plat is the air pressure at the level of the alveoli. P peak is the total airway pressure. It may not always be that a high P peak means a high P plat. Sometimes a high P peak may also be associated with a normal P plat. If there's a normal P plat, it means that the alveolar pressures are perfectly fine and there is no pathology at the level of the alveoli that is happening. It means the problem is somewhere higher above. Is this clear to everyone? Is this part clear to everyone? Yes, we are going to talk about this block TT tube and everything. Yes, okay. Is this clear to everyone else? Okay, thank you. Let's move to the next slide. Okay, now for this, I think I will have to switch my video on. Vijay sir, can you help me switch my video on? Okay, I think there's some technical issues for which I'm not being able to switch my video on, but I think this diagram of a ambu bag with a tube and a balloon should suffice. Can you all tell me something? That suppose I have inflated this balloon. Can you first see the diagram? You find an ambu bag which is connected to a tube and the tube is connected to a balloon, correct? Right? This balloon is inflated. The tube is having a certain diameter and the ambu bag is also inflated. Now, when I put a pressure on the ambu bag, there is a certain pressure which is generated in the tube plus the balloon. Is this clear to everyone? When I put a pressure on the ambu bag and compress it, there is a pressure generated in the tube plus the balloon. This total pressure of the tube plus the balloon is what I call as the P peak. Is this clear with everyone? But the pressure that is individually there in the balloon is what I call as the P plat. Is this clear to everyone? Am I clear? Perfect. Perfect. Now, do you agree that अगर मैं balloon के जगह football को inflate करता, if I was supposed to inflate a football instead of a balloon, do you agree that it would have been more difficult for me to inflate it? Which means if I replaced the balloon with a football, the P peak alarm would still be high. But this time the P peak would not just be high, it would also be associated with an increase in P plat. Because it is difficult to inflate a football than inflating a balloon. Inflating a balloon is easier because balloon is a more compliant structure. If it was a football, the P plat would have been higher and that would have resulted in the higher P peak. Agreed, everyone? Clean? Okay. Also, now let's remove the example of a football. Let's think the balloon hai and the tube is there. Now suppose something is blocking the tube. Do you agree that once something is blocking the tube or the tube has become narrowed or some kind of secretions have pulled into the tube, do you agree that the pressure in the entire system will increase? That will lead to an alarm setting off in the P peak? Do you all agree that when there will be some secretions or there will be some narrowing of the lumen of the tube, the P peak alarm will also be high? But now, is this high P peak associated with a high P plat? Now, because there is a secretion in the tube, will it be associated with high P plat? No, because the balloon is perfectly okay. There's a problem in the tube, which means a higher P peak may be associated with a higher P plat, as in case of a stiff lung, worsening ARDS, or it may not be associated with a higher P plat. It may be some problem in the circuit, ventilatory circuit, that is leading to a higher resistance. So let us talk of the conditions. When the P peak is high and the P plat is normal, that is either the tube might be kinked, there might be a narrowing, there might be some bronchospasm, there might be a mucus plug, or the patient might be biting on the tube. Maybe the patient has come out of sedation and the patient is biting on the tube. But if P peak is high and P plat is also high, that is the similar scenario which I explained, that instead of a balloon, if you were inflating a football, that is due to a decreased compliance. Something is blocking the alveoli. It may be pus, it may be fluid, it may be atelectasis, it may be pulmonary edema, it may be decreased chest wall compliance as we find in neuromuscular disorders like Guillain-Barré syndrome or myasthenia gravis. Am I clear about it? Everyone's clear? What are the conditions where P peak is high and P plat is normal and P peak and P plat both are high? So can I make one statement that a high alarm of P peak with a normal P plat makes me look for technical causes? Whereas a high P peak alarm with a high P plat rather, makes me look for a worsening pathology in the lung alveolus. Am I correct? Am I correct? Correct. Thank you. Thank you so much. Next slide. This is the last slide for the day. And actually, as I said, a 2-hour class on ventilator is not enough. So I'll be wrapping up this slide with this topic, that is what to do whenever there's a sudden hypoxia on a ventilator. So there are 3 things that you will do. Whenever a patient is having a sudden hypoxia on a ventilator, there are 3 things that you will do. First, look at the monitor. Second, look at the ventilator. Number 3, ask the nursing staff. What will you ask? What will you do? Is something that we will go in sequence. So what is the first thing? Whenever a patient who has been ventilated, was maintaining well, suddenly develops a rapid hypoxia or a sudden deterioration of desaturation on the ventilator. First is look at the monitor. First, see whether the monitor is connected properly. Kya pata that the oxygen ka waveform is not coming properly because the SpO2 probe has been dislodged from the finger. Check the BP, check the pulse. Maybe the probe has been removed, or maybe the at times you will find that the ECG leads have come off. That is giving some weird artifacts. So do not immediately get panicked. Look at the monitor and look at its connections. Look at the oxygen waveforms. Are they good waveforms? Are they stable waveforms? Check the BP, check the pulse. And if you have end-tidal CO2 available in your hospital, check that. Because end-tidal CO2 is the one of the best methods to check whether your tube is in position. Correct? Correct? Everyone's clear with this? Everyone's clear with this? Next, you look at the ventilator. What do you look at the ventilator? First, check the P peak and the P plat. If the P peak is high, with a normal P plat, it means there is some problem in the tube, or there is a bite, or there is a bronchospasm, or there is a mucus. And as I said, if it is associated with a higher P plat as well, it means either the lung is getting stiff due to ARDS or pulmonary edema. Read that and change the mode of ventilation, or change the settings of ventilation. Next, what if the pressure is normal, but the tidal volume is low? Suddenly, with the patient, I mean, the pressure alarm has not gone on. There's no alarm from the pressure end, but suddenly you are finding that the tidal volume that is being delivered is low. अब ये एक ही कारण में हो सकता है that till now the patient was being maintained on a normal tidal volume, the settings have not been changed, yet the tidal volume has started to decrease and the patient is having hypoxia. That can only happen if there's a leak in your system. Maybe the pilot balloon that you have used has ruptured, or maybe there's some leak that is there in the system. Try and fix the leak, which is a technical issue. Number 3, dysynchrony. Yani ki you had sedated the patient. Suppose this patient was sedated. Ideally, it is clearly said, again, this is something that I won't be saying today. Ideally, it is said on a ventilator, do not sedate the patient. Do not sedate the patient unless it is absolutely necessary. Only in some specific cases, you should think of sedating the patient. Otherwise, do not think of sedating the patient. So, if this patient was sedated, and yet you are finding a sudden hypoxia on the ventilator, that is probably because this patient is coming out of sedation. So apply a muscle relaxant. You can use something like atracurium or rocuronium. See for 20-25 minutes. Once the effect sets in, you will be finding that the patient is again maintaining well. Next, something which is called breath stacking. I'll be talking of breath stacking a little later. And the last is the ventilator is angry with you. I mean, ye to tabhi ho sakta hai if you have a really, really bad luck. You know, say there's a sudden cutoff of the oxygen supply in the hospital. The ventilator has become mad at you. The ventilator is not working. The circuit is completely gone haywire. The oxygen supply of the ventilator, the source of the central oxygen supply has gone off. For that, you really need to have done some really bad karma in your life. Otherwise, ye nahi hoga. So these are the points of looking at the ventilator. Last but not the least, ask the nurse. अगर ये दोनों चीजें सही है, then please go to the nursing staff and ask them very politely that, hello madam, this patient was doing fine 5 minutes back. Have you for any by chance taken off the plug of the ventilator for charging your phone in the same, port? I'm just joking, but ask this very politely. Don't be rude. Ask them, ki nurse, warden, staff, whoever is there, ki sister, did you by any chance take the plug of the ventilator out to charge your phone in that port? Or did you move the patient did you cause any movement of the patient? Kabhi kabhi kya hota hai, in order to clear secretions or in order to give any some form of chest, in form of head elevation or 30-degree recumbent positions or 45-degree recumbent positions, sometimes the patient is being moved. And any kind of movement at times can lead to dislodgement of the tube, especially in pediatric patients where the child is so small, the trachea is also so small. Even a 1 millimeter movement of the tube here and there can lead to dislodgement of the tube from the trachea. So first, go and ask the nursing staff कि दीदी क्या आपने फोन चार्ज दिया था इस पोर्ट में कुछ देर के लिए वेंटी को खोल के? Number 2, क्या आपने पेशेंट को हिलाया था? If you moved the patient, the tube might have got dislodged. Number 3, is the patient agitated? Check these 3 things. And only if you get an answer on these 3 things, then do these next set of things. Disconnect the ventilator. Yes, don't get afraid that, oh my God, what is Dr. Saab saying? Disconnect. Yes, disconnect the circuit. Do suction. In the moment that you are disconnecting, put an ambu bag and ventilate the patient with the help of ambu bag. Ambu bag ventilation in these moments help you in 2 ways. Number 1, it helps you understand the resistance of the circuit as well. Plus, it also gives you the feel of ventilating a normal lung. I mean, you'll be compressing the bamboo bag, releasing it, again compressing, again releasing. तो एक normal lung की feel भी देती है वो. Finally, do an ABG. See the values of the ABG. And again, I'm saying, don't try to treat the ABG, try to treat the patient. And finally, if available on bedside facilities, if you have a USG chest that you can do, or if you have a chest X-ray that you can do in order to rule out some spontaneous pneumothorax that might have happened in a patient. Because it is also one of the reasons that a patient can develop a sudden hypoxia, that is pneumothorax. So if you find such things, of course, as I said, look at the monitor, look at the ventilator, you will also auscultate the patient. If you're finding a silent chest, if you're finding no such things, of course, you will put a intercostal drainage in the or a needle in the second mid clavicular space in the for management of pneumothorax. So what I'm trying to say is, do these things only when you've looked at the monitor, looked at the ventilator, ask the nursing staff. Now, finally, what is breath stacking? Breath stacking is a very simple thing that we find in case of COPD patients. Iske liye, I would really want my video to be on. I'm trying to put my video on. And
you can switch on your video now, doctor.
Yes. So, am I audible? Sorry, am I visible?
Yes, you are visible, you are audible.
I want everyone to do this exercise with me. सांस की भी थोड़ी exercise हो जाएगी. And this is the last thing that we'll be discussing. So, I want you all to take a deep inspiration or a normal inspiration and exhale. You can see me doing that with you. Inspire, expire. Now, the exercise is, you will do a normal inspiration, but you will not leave the entire air out. By the middle of your expiration, you have to take the second breath. And again, by the middle of the second expiration, you have to take the third breath. Can you start doing it and tell me whether you feel comfortable or uncomfortable? Like, this is something that is going to make you feel comfortable or uncomfortable. Jab aap in the process of expiration, without having expired the air out completely, you're already taking the next breath. Is it going to make you comfortable or uncomfortable? Uncomfortable, exactly. This is what happens in case of COPD patients very commonly on a ventilator. Because there is air trapping and we have not adjusted the ventilator well with the patient, because I told you, ventilator is an idiot. उसको कुछ पता नहीं है. Patient COPD का है, pneumothorax का है, कुछ नहीं पता. वो उसको तुम बोलोगे भाई 5 सेकंड में एक breath दो, he'll give 1 breath. Finished. So what happens in COPD patients, because of significant air trapping, they are not able to release the trapped air out entirely when the ventilator is giving them a breath. So just at the time that they're wanting to expire, they're already getting a breath and they have to take an inspiration again. That is what is the concept of stacked breath. And how do you understand that this is the case of stacked breath? Check the ventilator waveform. Can you clearly see that in this place where there's a blue arrow? Dr. Rimjim, if you can please show me with the laser pointer. Yeah, with any pointer. Now, the blue arrow. Yeah. Can you see very clearly? No. Can you see very clearly that the flow This is the flow waveform, and the flow waveform is not touching the baseline. Can you see that this is not touching the baseline? Can you see the above diagram? That is the normal diagram where the flow waveform is touching the baseline. Yes, it is touching the baseline. But whenever you find that on the ventigraph, the flow waveform is not touching the baseline, you should always be aware that this is the case of stacked breath. In such a scenario, as I said, disconnect the ventilator. Because when you disconnect the ventilator, the patient can release out the trapped air, then reconnect the ventilator, or in that period do an ambu bag ventilation. It is going to be perfectly okay. That brings us an end to this marathon session on basics of ventilator. I have tried covering almost every basic that can be covered in 2 hours or 2 hours 15 minutes, and the box office is open for all of you. Vijay sir, it is up to you and the Mediversal team to take up a second session on ventilators, because as I said, ventilator cannot be completed in 2 hours. But I think I have tried to put up as much interest as I can for you to read about ventilators. And as someone who loves teaching and loves studying, loves being a student rather more than a teacher, it is my earnest request to go to Google and search by the name of Dr. Eric Strong, ERICSTRONG. You will find a lot of free lectures of Dr. Eric Strong on the internet, which is based on ventilator. I think they're called Strong's lectures. I'm not remembering, but it is so damn good. After the base that I've set for you, it is going to be very easy for you to go through them. Go through them at your own pace. I'm very sure you will be understanding it as beautifully as I have said, or maybe even better. Dr. Eric Strong is one of the finest critical care specialists that we have, and his lectures are very widely studied by students, including me. So I will tell you to go through Eric Strong's lectures. They are absolutely free for you to watch on YouTube. And at some point of time, when Mediversal gives a platform again, I will always be loving to take uh, a section or a class on ventilator. And maybe at some point of time, because Mediversal is also conducting workshops, and once the workshops are gradually start to expand, I think we can have a ventilator workshop for maybe 2 to 3 days, where I can stand in front of the ventilator itself and show you the simulation modes in which a patient is ventilated, and what are the modes that we have in order to uh, read the ventigraphs better, understand the ventigraphs better, and also understand कि किस patient को क्या ventilation देना है at what point of time. I know there are several topics which I could not complete today because they were never supposed to be done today. As I said, Dr. Twinkle, I know I did not talk on CPAP, I did not talk on mechanical ventilation, I did not talk of circuits, because as I said, my first work is to create a base from where you all can start loving this topic of ventilator, and you don't get afraid. Because when I was of your age, when I was doing my MBBS, trust me, I never understood what a ventilator is because nobody taught us. The truth is, nobody teaches you and they expect you to know. So I still don't know how that happens, but my work is to at least not make you afraid, so that you all become dhurandhars in your own life, in your own fields, because you all are dhurandhars in your own field. So be brave and go through Strong's lectures if you can, so that next time when I take a session, you all can participate even better with me, and maybe you can also teach me some new things which maybe I can incorporate in my future sessions. So I have taken every doubt that I could, and there also are no more questions that I expect from you. But yes, I mean, I'm so glad to be taking this session and having so many of you, despite having such a long session. I'm so glad that all of you remained here. Dr. Twinkle, I think she wants to unmute herself. Dr. Vijay sir, can you help her unmute herself?
Yeah, done. She can unmute.
Yeah. Hi, Dr. Twinkle. Yeah, you can please tell me your questions or whatever you have
Good
to tell
evening.
me.
Good evening, sir. No, it's a really beautiful basic lecture. Those who are already understand, those who are fresher who's working in the ICU, because sometimes they brought the patient from ER and starting the venti haphazardly without putting necessary putting a data, RR, tidal volume and all, and then after certain hours we are repeat that ABG and reassess the scenario, become totally changed when that what patient condition is totally changed when previous condition. So I'm really glad that I'm already attended and part of your lecture. Thank you
Thank you
so
so
much,
much.
sir. Thank
Thank you.
you.
Thank you so much, Dr. Twinkle. It's a pleasure having audiences like you. And like, I'm so glad. And maybe at some point of time when we conduct a ventilator workshop, I would love to have you there with me, helping me with the ventilator machine and simulation models, because you are also working there, and it would be a pleasure to have you. And thank you, all of you. I'm so thrilled and so glad. And even though I'm having a very very bad back pain, it is worth it. It's worth putting in the effort, because you all make me stronger through these journeys, and you all make it so much better and so much worth this entire evening, that I can be in pain, but I still know that you all are there with me. So thank you for being my right hands and my left hands, and making me a stronger version of what I can try doing. Next class on ABG. My dear, I have already taken a session on ABG, Dr. Vivek, but ventilator settings, absolutely I can take. I can definitely take my next session on ventilator settings. ABG is something that I've already completed. So you can go to YouTube and look at those lectures. That is complete. I have completed the entire ABG for you. I've given a lot of case scenarios there. And thank you to each one. I mean, I'm Dr. Shashi and Dr. Jambavat, Dr. Gladys George. Thank you so much, Dr. OP Gautam. Uh, it means a lot to me, Dr. Mayur, Dr. Pratibha. So thank you so much for being there. And I would now give the platform to Vijay sir to speak and talk about whatever he wants to communicate to all of you. Yeah,
Great.
I would love to teach you all more. Absolutely. Thank you so much. And it's not just me teaching; it's me learning through you as well. So thank you so much for being such a wonderful audience.
Great, doctor. Thank you. As always, I don't know what I should tell because at the end of every session, I always end up saying it was really good session. And now that it has been an habit, I don't think that same words will suffice the effort.
It
So
means
I
every
would
time to me. It means the same every time to me. Thank you so much.
I would refrain. I would want to refrain saying those sentence, and I'm kind of searching the words to put together so that I don't know how to express the feeling because sitting 2.5 long hours in a session is really something commendable by both the parties. One with be you as a speaker, one be as a attendees because uh, I know what it takes to sit for 2 hours. So it is something really commendable, and the way you speak is always it goes without saying. It is always on an expert level. Thank you so
Thank
much.
you.
I don't want to make it more cliche uh, to add more thanks to you. So it is a privilege to have you on the session today, and
Thank
it is
you. Thank you
always
so much.
been.
And thanks to all of you, because for you I got to inflate balloons. बहुत सालों बाद I inflated balloons. I actually got these balloons so that I could demonstrate in the class. So thank you. Getting my childhood back after a long number of years. So
that,
thank you
that,
for
that,
that.
that is how the process works, right? So we always find a way to go back to our days where what we learned, and these things will make us more special. And really thanks, doctor. Thank you so much for taking that effort, making these things possible. And yeah, just a small announcement. I have dropped the certificate link, and also QR code is already present on your screens. You can scan either or can click on the link which is on the chat box to get your certificates and to submit your feedback. Your feedback is really important to us, and this kind of uh, engagement with you what thrives Mediversal Academy to keep on doing these webinars, and we assure you that this session will be uh, on track each and every month. So we'll be releasing our April calendar very soon, and I still do have two more webinars. Please do follow us on social media to get more information about that. Let me also drop our social media links with categories so that it might help you in following them. And
Vijay sir, can you please forward me the link for the certificate in my WhatsApp chat as well?
yeah, sure, sure. I'll do that.
Thank you.
I'll
Thank you
do
so
that
much.
right away. And I would also want to extend my thanks, or I don't know what again, it feel too cliche to say thank you today. But Rimjim, Dr. Rimjim, thank you so much. Thank you for sharing the screen. And if anyone wants to come on mic, if you want to give feedback to us, you are free to do. Meanwhile, we give us you submit your certificates. Back to both of thanks. Thank you, Dr. Rimjim. Thank you for sharing us screen and helping us. And I know you might have all. Thank you so much. Thank you so much.
Thank you so much. I am, thank you, Vijay sir. I've got the link.
I have again dropped the certificate link on the
Yeah,
form.
it's
Chat
an
box.
honest request to all of you to fill the feedback form, because trust me, your feedback is extremely valuable, and we take all of your feedbacks very seriously. Our team really works on it, and even the content for the webinars and something is something that we entirely decide based on how your feedbacks are, and we are absolutely nothing without you. So we would want you to be filling it up. And thank you so much for being a part of this marathon session. But I'm sure whenever you'll be going to sleep today, you'll be going to sleep knowing that okay, you are no more scared of a ventilator. That's something that was my objective before I started the session, and I just hope and pray that I've been able to fulfill that. So
as a non-doctor, I lost my scarcity today. So as a doctor, people should learn that. But anyway, Dr. I would like to take one line from your statement. You told, "Without you, we are nothing," and I would 100% vouch on that statement. Mediversal Academy, one such company where we always thrive on our students, thrive on our uh, attendees. So it is one such place where you can really see what you really mean. So thank you so much, and thank you, and thank you all. Thank you everyone for sitting. I know it is not easy, and I by this I can also tell what the topic weight. So thank you so much. Thank
thank
you
you
all.
so much. Thank you to each one of you. Thank you.
Thank you, doctor. Thank you, Rimjin. Thank you all. Good night.
Thank you.
Happy
Thank you
weekend.
so much.
Happy
Okay,
weekend to
happy
all.
weekend to all of you. Yeah.